One.
You on the other side?
Good luck.
Good luck.
Good luck. Welcome, and thank you for coming to the first time ever virtual webinar for Rotary District 5360. Our DISCON 2020 Rotary Crushes the Curve is a unique and different webinar that is rarely seen in Rotary, especially with this COVID crisis. I'm excited to say that we have virtual attendees from all over the world, Scotland, the Caribbean. Rather than registration fees this year, we ask for donations in support of families and women in emergency shelters across central and southern Alberta and western Saskatchewan. I'm so grateful to announce that we have raised almost $14,000. Thank you for your donations today. We'll officially open today's webinar with Assistant Governor Manon Mitchell of the Calgary Civic Symphony for the Canadian and American national anthems. Please go ahead, Manon.
You know the words, sing along. There we go. And now for our Canadian anthem.
Thank you, Manon. That was beautiful. I just love hearing you play the violin. You're amazing. Thank you so much.
Thank you.
Now we'll move into our Indigenous welcome and sharing with Laura Lee Higgins. Laura Lee is a Rotary Peace Scholar and one of Rotary's newly established Rotary Peace Activators. And thank you, Laura Lee, for taking the time today, and please proceed.
Oki, Dani Tada, Amba Wistich, Tanche, Dishinakashun Lorelai. Hello, everyone. I'm Lorelai. The languages that you heard are some of the most of the majorly used Indigenous languages in and around Calgary and in Treaty 7. It's such a pleasure to be here today and to be here to share some Indigenous wisdom and to just show up as my connections with Rotary. So I just want everybody to take a big breath. Just take a big, big breath in. Close your eyes if you want. We can't see most of you anyway. And just think about where you're located in time, in space, the very seat you're sitting on. A lot of us are actually calling from Treaty 7. And so as we think about the land we're sitting on, think about it as being the home of the Blackfoot Confederacy, the Tsuut'ina, the Stoney Nakoda, the homeland of the Métis Nation Region 3, and to other urban Indigenous peoples who call this home. So just think about where you're situated. The elders say that everything happens on the land. And so that's the teaching I'll share at the very end here today. Today is going to be an incredible day. With the theme alone, Rotary Crushes the Curve, and with the lineup of people that we have to speak and the conversations we have, I have no doubt that today will be filled with meaningful conversation followed up by powerful action. Rotarians truly are people of action. So I'm coming to you today feeling incredibly lucky. As Christine said, I have been involved with Rotary in a number of ways. I was a Rotary exchange student at the tender age of 17, and I went to South Africa. I most recently was a Rotary Peace Fellow in Thailand at Chulalongkorn, and now I have the privilege of being a Rotary Peace Activator. So I'm so excited to come in all those capacities. So as we talk today about COVID-19, I've been talking a lot to our elders and asking, what is the Indigenous perspective on the pandemic? What can we learn from this? What do we know about this already? And some of the things that were shared with me, and the two things the elders wanted me to convey today, was to think about how interconnected we truly are, and to also think about Rotary. And that is really poignant because Rotary is family. And so when we think about those two things and what it means, those are really, really powerful. So the elders had said over and over to go back to the land. So today, many of you can see behind me, there's a giant rock. It is actually the Okotoks-Eratic. So if any of you haven't been out there yet or haven't made the time or don't know it, I strongly encourage you to go. And this particular teaching is really relevant because the elders say rocks are really powerful. They're so strong. And so when you're feeling lost or ungrounded, just hold on to a rock. These are really big rocks to hold on to. So one of the stories that was shared with me recently was during the glacial age, 30,000 years ago, when these rocks were deposited. There is legends and stories from the elders that there was actually Indigenous peoples living on this land. And during the glacial age, they left to actually go to Asia. And so these rocks have stories of some of the last pandemics and how we survived as human beings and how interconnected we actually are. And the rocks hold these stories. So when you, over the next bit, try to navigate all of this change, all of these things that are happening, so many unknowns, try to go out to nature, connect back to the land, find that interconnectedness, find that meaning, find your connection to the ancestors and to each other, and get perspective. So today I just wanted to share with you and from my elders to take care of yourself, to take care of each other, and to keep connected through our families, including Rotary. So many, many thanks for the opportunity to do this, Marcy, and we'll see you all soon.
Thank you, Lorelei. You know, I always feel blessed when you give these welcomes, and thank you so much for sharing with us today. Well, we have a very special welcome today as well from our Rotary International President this year, who has recorded a welcome for us.
Hello, fellow Rotarians. I am Mark Maloney, the President of Rotary International for 2019-2020. I know that this is an unusual way for us to meet, but these are unusual times, and we are certainly doing our best to meet the Rotary Action Plan goal of increasing our ability to adapt. As the COVID-19 crisis began to impact the world, country by country, Rotary's way of reaching out, hand to hand, person to person, had to be put aside. But our powerful need to connect with each other has never waned, and our unique ability to lead and work with global organizations has never been more important. As I have watched the many ways you and all within the family of Rotary have connected the world with your actions and your compassion, I have never been prouder to be a Rotarian. We are facing a serious but temporary challenge. We will get through this by working together and taking care of each other. Just what Rotary members do. I know this because Rotary connects the world. And this has never been just a slogan for me. I really believe it. Rotary connects the world is a description of how and why Rotarians achieve so much. We invest in relationships. We make decisions grounded in evidence. We know how to mobilize our networks to create solutions that last. And we are always learning from our experiences in projects, clubs, and careers. In this time of social distancing, everyone feels a renewed hunger for meaningful social connections. We miss seeing our friends face to face. We yearn for the kinds of meaningful conversations and shared experiences that we may have taken for granted for much of our lives. In short, people are looking for the Rotary experience now more than ever. As we use our connections to recover from this era of distance, we will face new opportunities to grow Rotary in innovative, sustainable ways. Thank you for your leadership at this important time. Take care of each other. I look forward to seeing you in person soon.
So moving right along, we'll present for you today two panels. So you've already seen the posters. I'm really excited that we have joining us today some really great medical professionals and some fantastic Rotary people of action. We'll move right into the program. I will be introducing Kathy Lee. Kathy is an anchor and video journalist for CTV News in Calgary. She's a recipient of the Spirit of NATE Alumni Award for displaying excellence in journalism. She is also the recipient of the 5 RTDNA Awards for her investigative pieces and documentaries. Some of her proudest achievements include a documentary she produced that covered exclusive and shocking government reports around private childcare in the province and a documentary on the impacts of the opioid crisis on frontline workers and families in Calgary. So thank you for joining us today, Kathy, and I'll turn it over to you.
All right, thanks so much, Christine. Good afternoon, everyone. Thank you so much for that introduction, Christine. As Christine said, I am an anchor and video journalist with CTV News in Calgary, and I'm honored to be a part of this year's district conference as moderator for the first panel, COVID-19 Facts and Fiction. Thank you, everyone, for joining us today. It's been a very busy few months for myself as a journalist covering the COVID-19 pandemic. I find even in my position, sometimes I can get really overwhelmed by all the information that is circulating. And especially with the different types of mediums that you can consume news, there can be quite a lot of information. So I understand how difficult it might be for some people to keep track of everything. But more important than the volume of news that is being put out, it can get frustrating to determine what is true and what isn't true. And when it comes to your health and protecting yourself and your loved ones, it's important to be getting the facts. So this is what this panel is going to help out with you guys today. The 3 panelists joining us will answer your most pressing questions. They'll set the record straight. They'll dispel some theories that might not be true. And most importantly, they will arm you with factual information that you can use to help you navigate this pandemic, okay? So I'd like to introduce really quick, off the top, Dr. Raj Bhardwaj, Dr. Tyler Williamson, and Dr. Lenora Saxinger. Each of them will do a presentation in their area of expertise. So the thing is, each will only have 12 minutes, and my job as a moderator is to ensure everybody is on time so we can end on time and get the, okay? If there is a pressing question during each of their presentations, then go ahead and maybe pose that question. However, if you can hold off until the end, I promise you there will be plenty of time to ask questions, okay? I will ask some questions first and then go ahead. I mean, this is a new world here. I'm not an expert at Zoom, but I'm going to try to figure it out. And I think Charlene is going to help me try to field those questions. So without further ado, let's begin. I'd like to welcome our first panelist, Dr. Tyler Williamson. He is the Associate Director of the Center for Health Informatics at the University of Calgary. His team has been advising Mayor Naheed Nenshi and provincial leaders on COVID-19 related informatics, the differential effects of the pandemic on vulnerable populations, and what policy measures have been taken around the world. Dr. Williamson will be speaking about how the first 100 days or 93 days have gone in Alberta and a few speculations about what happens now. Without further ado, you may begin, Dr. Williamson.
Thanks very much, Kathy. I'll just begin by sharing my screen. Thank you for the introduction and thank you for the opportunity to speak. It's my privilege to speak to you about COVID. I know that we're already a little behind schedule, so I'll do my best to try and catch us up a little bit on that. I would be remiss if I didn't begin by acknowledging, though, the support of the Rotary Club of Calgary at Stampede Park. Almost days before COVID began in Alberta, we received some support from the Rotary Club of Calgary at Stampede Park. And it couldn't have been more prophetic. It has been instrumental in us being able to respond in this way to the crisis, and so we are enormously grateful to have been welcomed into the Rotary family very recently, and really appreciate that support. So thank you very much. I'm going to try and tell a bit of a story about our experience with COVID in Alberta. I recognize that not everybody's from Alberta, but I'll focus my remarks on Alberta, and hopefully they can expand to what we're seeing elsewhere in the world. March 5th was the arrival of our first case of COVID-19 in Alberta following some international travel. And for that first week, or about 9 days until that first weekend, it was a relatively quiet storm. There was not much action, not much happening. And then on March 14th, we received a call from Mayor Nenshi as cases began to rise, saying, where is this going? What's our experience going to be here in the city of Calgary and in the province of Alberta? And what does the evidence tell us around what we should do? And in response to that, the University of Calgary responded in many different ways. In fact, actually, it might be one of my favorite, I'm a perpetual optimist, and it might be one of my favorite parts of this whole terrible circumstance that we find ourselves in is how this pandemic has brought communities together. And as we've turned to our neighbors and as we've all worked together, it's been inspiring to me on many different accounts. The University of Calgary was no different. We've responded by doing a number of different things because we want to be a resource to our community. We've created a COVID page that I could direct everyone to if they're interested, that has podcasts and webinars and tips for coping with isolation, things like how you might do online learning or things like that in your spare time. And we've seen responses at almost every level of the university. We have basic scientists working on some incredible things, trying to sequence the virus and different things like that. The University of Calgary previously had a level 3 lab space, and that didn't mean much to me because I'm not a lab scientist and before this, but level 3 lab spaces are very uncommon in Canada and in North America. They have special security around, like entering and exiting and different things like that. And we've dusted off and refurbished our level 3 lab space to be able to support critical COVID-19 research. An amazing story would be the work being done by Dr. Mahoney about how he's pivoted from his revolutionary work in cancer to trying to help find a vaccine for COVID-19 and contributing to the global effort on that. been an amazing thing for me to watch. That's not what I'm going to tell you about. I'm going to tell you about my experience in COVID-19. As Kathy mentioned, I'm the associate director for the Center for Health Informatics. I hope my sound's coming through okay. I recognize that my internet is giving me some grief at the second. And the Center for Health Informatics at the University of Calgary brings together health data from all over the province and all sorts of different sources. And that allows us to do many, many interesting things related to studying the health system and all sorts of things like that. So as you can appreciate, as we struggled through trying to find out what to do about COVID-19, and our colleagues at the province of Alberta and our colleagues in this, the city were saying, well, where's this going to go? We got to try some modeling. We got to try some predictions. We did our best to try and be responsive to those things. And so what we have done is we've tried to look at the experience of other nations. There was a lot made. In fact, I had a number of meetings over because of the projections that we all saw for the province of Alberta. As time has played out, obviously those projections were inaccurate. But I think we put the scientists that were asked to do those in a very difficult position by saying, a few days into the pandemic, where's this all going to end? And the analogy that I would draw it to, since we don't have any hockey happening, I'll try and use as many sports metaphors as I can. It was like trying to predict who was going to win the Stanley Cup on the third day of the season. And obviously we know that that's a very difficult thing to do. And I think that a better approach is the approach of trying to look to the rest of the world and the experience of the rest of the world, and to try and inform what might happen here in Alberta, here in Calgary, and throughout the province. So with that in mind, that was the birth of something that we call CHI-CSM, or COVID Tracker. This is a live website that you could go to at any point. And it asks the question, or poses the question, how is Canada doing and what should we be doing next? And it presents all sorts of different information about our experience with COVID, how we are, or if we are, flattening the curve. But I think the interesting part is that it juxtaposes policy decisions that have been implemented elsewhere in the world. So on your screen now, you'll see 3 different countries, and unfortunately I elected not to go with a live demo, otherwise I would have shown you these specifically. But the pink or purple line up near the top is Italy. The blue line in the middle that gets nearly as high is Germany, and then the green line down below is Alberta. And if you go to CHI-CSM and you hover over any one of these little circles, you get to see what policy intervention was made in that country or that jurisdiction in provincial cases at that time in the curve. Because as the number of cases was ramping up and everybody around the world is clamoring to try and decide what to do next, we know that there were some things, and there were lots of experiments happening that informed whether or not the right decisions were being made, and to what extent or what influence those were having on the curve that we were all trying to flatten. So I would love to show you more of this. I don't have time at this point, but I'd invite you all to go to CHI-CSM. I'll put it in the chat or in the Q&A after. And feel free to poke around and see the experience of many countries around the world. You can select almost any country anywhere. Now, the 100 days, the question here is, how's it going? All the attention was for a while there on this concept of flattening the curve and how that was happening. I think there are some good news stories. I can tell you that since April 30th, an epidemiologic construct known as the effective reproduction number, which is essentially an estimate of how many people each person infects, gives us an idea of whether the pandemic is spreading or whether it's in a state of dying out. And since April 30th in Alberta, our effective reproduction number has been below 1. And what that tells us is that we are in a state where pandemic is slowly diminishing or going away. Now, that doesn't mean that it will forever go away, but that means that right now, as long as we can keep that effective reproduction number below 1, that's where we want to be. In the interest of being brief, I'll show this to you very quickly. One of the best repositories in the world is the one that's been created by the Johns Hopkins people. We've had some collaboration with them related to this, but if you'd like to look at, here's the number of daily cases in Canada. Gives you an idea of where we are along this trajectory. That would suggest that for sure we're well past this first wave. And then other countries, Germany, much further past their first wave. And then there are other examples that we could look to, maybe not good examples, but other examples we can look to about where they are in their experience. If we look at the US as an example, they're having a much more sustained reduction in their cases. As we know, they're leading the world in COVID infections so far. Now, in terms of where we go next, and I'll be brief about this part as well, excuse me, as well. One of the things that I think we need to keep in mind through all of this, we reacted very quickly in the province and have had wonderful testing. And I think that has saved many lives. But I think it's important that now that we're in this new phase, that we think about what happens next. And it's important that we don't act too slowly as we start to lift some restrictions. Here's some of the information that we've shared with the province and with the city around relative actions that we might want to consider relative to an assessment of whether they reduce transmission widely and how impactful they'll have, or how impactful they will be on economic activity. And so obviously we want to see nothing down here. We want nothing that doesn't work and greatly impacts the economy. And then the things farthest up in this corner were things that that are maybe at the other end of that spectrum, right? That may have very low detrimental impact on the economy, and they may or may not, or they may have a larger effect on reducing transmission. So I will wrap up by saying that we're continuing on with policy work related to these things. And I want to mention that, again, like I said, there's risks to opening too fast, but there's also significant risks to opening too slow. And we need to be thoughtful and careful about that. We have some plans that we'll be launching next week, actually, or the plan is to launch them next week, related to helping Albertans and Canadians get back to work and strategies for that. And with that, I will pause and turn it over to my other presenters. Back to you, Kathy.
Oh, there we go. Hello. Thank you so much, Dr. Williamson. We do have a question, but I think we'll continue. You know what? Here, hold on. Okay, how about we just go ahead and answer this question really quick. It's from Brian Carnahan. What is causing the cyclic increases and decreases in the number of daily new cases? Dr. Williamson, can you answer that?
I can sure try. I wouldn't mind having Lenore and Raj jump in as well if they have things to add to this. But there is going to be some amount of variability between different daily estimations. There's a number of different things, and some variability is to be expected. The question is, when do we become concerned about that variability? I'm not sure that we have a definitive answer in the, if there are clear cyclical patterns. So I don't have a clear answer for him, unfortunately.
No worries. We can always go back to that question later if Dr. Bardwaj and Dr. Singer would like to weigh in. So thank you so much, Dr. Williamson, for your presentation. We're going to move on. I'd like to introduce Dr. Raj Bardwaj, who is an urgent care physician at the Sheldon Schumer Health Center. He is also an assistant clinical professor with the University of Calgary, a health medical columnist for the CBC, and host of the DDX podcast. Dr. Bardwaj will give us a brief look behind the curtain of the healthcare system in Calgary during the pandemic, specifically at the Sheldon Schumer. And then he will talk about some myths around COVID-19. All right, you may begin, Dr. Bardwaj.
Hello, hello.
Hello.
I'm gonna try to start sharing my screen. Let's see what that does. How's that? Can you guys see that?
Yes,
Am I
you're
seeing
there.
it? Fantastic. Can you also see me? Because I can no longer see myself, which I'm cool with, actually. I don't like seeing myself on video. All right, here we go. So, good afternoon, everybody. Thanks to Christine Rendell and Rotary 5360 and all the Rotarians for inviting me to speak today. I'm going to talk about a couple things okay, I just got a message. There we go. I'm going to talk about a couple of different things, like Kathy said. I'll give you a little bit of a look behind the curtain of the healthcare system in Calgary during the pandemic, specifically where I work, which is the Sheldon Schumer Health Center downtown. And then I'll talk about a couple of myths. And hopefully, after today's talks, you'll be more confident in your knowledge and your understanding of the virus and what we need to do to keep punching it down. So let me see if this works. There we go. That's where I work. That's the Schumer Urgent Care Center. So for those of you who don't know it or don't live in Calgary, this is a 24-hour urgent care center in downtown Calgary. We serve the community that lives and works and plays around Calgary's inner city, which are the sort of dense urban neighborhoods that we watched being hit really hard in Italy and in the United States, like New York City and Seattle. So luckily, before COVID really hit Calgary, we had lots of warning, and we used that time very wisely, I think. Roughly from about mid-January to mid-March, we used that time to review our current practices and to change pretty much everything, actually, about how we do things. So we needed to consider what had happened in New York and in Italy, where they really did have different phases to the pandemic where they became absolutely overwhelmed. So we had to consider what happens if we're overwhelmed by the simple numbers of patients. We also had to consider all sorts of logistical things. So like when a patient comes in with symptoms of a flu-like illness, how do we keep them safe? How do we keep that patient safe? How do we keep other patients safe in the waiting room or in other patient areas that might be just separated by curtains, right? Like we've all experienced that in hospitals and emergency rooms. Also, I think equally importantly, how do we keep our staff safe and ourselves safe? We saw that in other countries, a lot of doctors and nurses were getting sick, and probably they were also spreading the infection from patients with COVID-19 to others, maybe people at home or other people that they met during their day-to-day life. And we couldn't repeat those types of slip-ups. So we started to alter our infection control measures. We had even more strict hand washing and hand sanitizing and stuff. We were wearing masks for patients who had infectious symptoms, and eventually, and to this day, we're actually wearing masks for every patient that we see, no matter what their symptoms. We were rearranging waiting rooms. We were dividing them into higher and lower risk areas for people with and without infectious symptoms, plus, of course, spreading out the chairs in the waiting rooms and increasing cleaning protocols. So this is a rough sketch of what the floor plan is at the Sheldon Schumer. And we have a lot of rooms, a lot of patient rooms. All those red rooms at the beginning were assigned to patients who were going to come in with flu-like illness. And the blue rooms were sort of our relatively clean or low-risk rooms. We changed, that means changing the flow of how we bring patients to rooms and how we take people to x-rays and just absolutely everything. And all through this, we were learning, and the whole world was learning about COVID-19 in real time. There were literally days when I would come to work and there would be different procedures and policies in place than the day before, because we had learned more and we had learned and adapted our system. So when we were learning things like reports from New York City hospitals that said up to 70% of people who were admitted to New York City hospitals with COVID-19 had no fever, we had to change things. When we basically spent hundreds of hours in online meetings thinking about everything from when a person enters to when they leave, including after they leave. How do we deal with people who can't self-isolate because they live in shared housing or if they're homeless? So we sort of looked at the different phases. So this, you'll notice that there are more red rooms. We're thinking, what happens if, for example, somebody comes in and needs our resuscitation room? That's the triangular room on the left-hand side of the map. The room where the sickest people are taken, people who aren't breathing, or who suffer a cardiac arrest or a severe overdose, where the most aggressive treatments are given by a team of doctors and nurses, inserting breathing tubes into a person's windpipe, where we give chest compressions and medications, even shock the heart to try to get it beating properly again if it's stopped. Those things, all of those things that we do to bring people back to life, also increase the risk that we will be exposed to the patient's respiratory secretions, their saliva, when it becomes aerosolized or airborne. And that potentially exposes every person in that room to COVID-19. So we had to rethink, reorganize, relearn. We created a second resuscitation room in our isolation room, which is usually reserved for people who might have very infectious diseases. It's a negative air pressure room. So that's a room where all the air gets sucked out of the room and filtered and not recirculated into the rest of the building. And we rejigged things again. We had to change protocols to make sure every person who was helping with resuscitation was in full and proper personal protective equipment, or PPE, which I'm sure everybody's heard a lot about. And then we practiced and we practiced and we practiced over and over again to get used to the new environment, the new protocols, having to do all the things that we're used to doing, like starting IVs and intubating people and stuff, but wearing masks and face shields and not being able to hear each other properly and wearing gowns that are hot and stuffy. So all of those things, those are some of the ways that the emergency rooms and the hospitals and the urgent care centers, all health facilities, have adapted to this game-changing virus. And because of all those adaptations, they're safe. So safe that the risk of catching the virus is actually lower for healthcare workers than it is for the general community. So safe that I often feel safer going to work than going grocery shopping. So safe that I can say without reservation that it is safe for you to come into the emergency room or urgent care if you need to. So don't delay your care out of a fear of getting exposed to COVID-19. So, like I said, we were learning about COVID-19 in real time, which is great, but that also has some downsides like paranoia and hype. Some doctors were really worried that we would run out of PPE, and that wasn't an unreasonable fear given what we were seeing coming out of New York City and Italy and places like that. Doctors started showering before leaving work. They started treating their hospital clothes, their scrubs and stuff, and even their shoes like hazardous waste. And at work, some doctors decided that they would be safer wearing industrial strength PPE that they bought on their own. This is a colleague of mine. A lot of those personal practices happened because of fear or because of rumors about the virus. And that has happened in the general population as well. Myths and rumors have sprung up like mushrooms after a long reign. So there are dozens of rumors. We don't have time for them all, but let me talk about 3 of them real quick that we can deal with others in the Q&A if you want. So the first one, which I don't understand, but it's here. Actually, I kind of understand it. This is a virus or the rumor that the virus came from a secret lab, that it was created and released either on purpose or by accident. This one has exactly 0 evidence to it. So I understand that these rumors, they come about because people look around for somebody to blame. Like, who can we blame for this virus? And that lends itself to conspiracy theories. If a person were to create a deadly virus, what better place to release it than in a densely populated area, right before a huge holiday where people will be traveling across the country, across the world? It reads like science fiction, like lazy science fiction. But the more we learn about this virus and its genetic code, the more we see that it's very similar to other coronaviruses that are found in nature, down to those little crowns, those little red things on this graphic. Those are what allow the virus to attach to and enter human cells. But even not just those crowns, but the genetic backbone of the virus is actually different from genetic backbones that have been studied and worked on in viruses around the world. It would be a lot easier to use the backbone of the original SARS virus or MERS or something like that, rather than to start from scratch. But starting from scratch is what happens in nature all the time. And that's what we see with this virus. Another related rumor was that this was actually a naturally occurring virus that was somehow released from a lab, like tweaked and then released. And the conspiracy theorists add that there is a lab in Wuhan that studies bat coronaviruses. Well, there's no evidence for that again, and there's plenty of evidence against it. So we can't go too far down the conspiracy rabbit hole here. I mean, that's what the internet is for, really. But the short answer is that spillover of viruses from animals to humans happens once in a while, about once per decade on average. And you've already heard of those outbreaks. Swine flu from pigs in Mexico, bird flu from, you guessed it, birds in Africa and in Asia. Ebola, probably from bats in Africa. SARS, the original SARS, again, probably from bats, maybe civet cats in Asia. MERS from camels in the Middle East. It's happened before. It's going to happen again. Hopefully, because of all the prep we've done this time, we'll be even more ready next time. So, on to another rumor. Blood pressure medicines, anti-inflammatories being dangerous when combined with COVID-19. So to understand this rumor, you have to understand there's three pieces of this puzzle. So first, there are a lot of different types of medications that doctors use to treat high blood pressure. One class is called ACE inhibitors. ACE is an enzyme, a chemical helper, converts one chemical called angiotensin 1 to another chemical called angiotensin 2. Scientists aren't very good at naming things. So angiotensin converting enzyme, or ACE, is what does that. So by inhibiting or slowing down that conversion, ACE inhibitors can lower your blood pressure. So all these meds have names that end in pril. So lisinopril, perindopril, captopril, and so on. During the break, run to your medicine cabinet, see if you're taking one of those. That's the first piece of the puzzle. The second piece of the puzzle is that the one way that the coronavirus gets inside the cells in our lungs is by picking a lock, so to speak. And that lock that it picks is a lock that's usually meant for angiotensin converting enzyme. So those ACE receptors are the locks that the virus picks. And we have ACE receptors on the inside of our lungs, on all over our body, actually. The third piece of the puzzle is that early in the pandemic, we were seeing reports that people with diabetes and high blood pressure and heart problems had more severe disease and were dying out of proportion to people who didn't have those conditions. So some scientists sent a letter to the British Medical Journal, not a study, a letter. And they said, maybe it's not that those folks were sicker or at higher risk because of their diabetes or their high blood pressure or even their heart disease. Maybe it's actually that they were on ACE inhibitors. And maybe, it's actually a lot of maybes in here, aren't there? But maybe those ACE inhibitor medications actually increase the number of ACE receptors in our cells. And maybe that's why they did worse. So on the surface, it seems like maybe it's a possible theory. It's a plausible theory, but there's actually no evidence for all of that so far. And a lot of the deeper science behind their theory actually comes from research on mice that's never been replicated in humans. So at this point, there's no evidence that taking ACE inhibitors is a risk for worse disease. So please don't stop taking your blood pressure medicines. A related rumor popped up around non-steroidal anti-inflammatory drugs, things like ibuprofen, which is Advil or naproxen, which is Aleve or Vimovo. This one comes to us actually thanks to the Minister of Health in France. He tweeted that ibuprofen and other anti-inflammatory drugs might be unsafe for people who are sick with COVID-19 because maybe, there's that word again, they also increase the number of ACE receptors, those locks that the coronavirus picks. And again, maybe plausible, based on some mouse research. And again, never shown to happen in humans. So if you want to take an anti-inflammatory for your symptoms, that's fine too. Last rumor, real quick. This one just popped up in the last couple of weeks. It's about masks. There's been a push around the world to get people to wear non-medical cloth masks to help decrease the spread of the virus in situations where distancing or hand washing isn't immediately available, like on the bus, some indoor environments, things like that. And a rumor has started that wearing masks is actually dangerous. It's bad for you because it makes you rebreathe the air that you just breathed out. So that's higher in carbon dioxide, and rebreathing carbon dioxide is bad for you. So like almost all of the rumors on the internet, they're anchored to some small truth, some tiny piece of evidence. And in this case, the tiny piece of evidence that it was anchored to was a study in 2006 that online memes point to as evidence for increased carbon dioxide levels with mask use. And there was a study. There was exactly 4 people studied in this. They were all doctors. They were wearing an N95 respirator, actually a PFR95 respirator, same kind of thing, which is specifically actually what we're asking people not to wear. But anyway, the doctors had their carbon dioxide levels in the air measured, so between their face and the mask. They had those air levels measured, and the carbon dioxide did increase after about 20 minutes of wearing the respirator. But the doctors didn't actually report any similar CO2 levels. And even in that tiny study, the authors said that clearly our findings are of uncertain practical significance, and then said, you know, like any good scientist, said we should do more studies. But unfortunately, those studies haven't been done. But really, this study isn't applicable to the current situation because we're talking cloth masks, not tight-fitting, high-efficiency respirators like they used in the study. Also, masks aren't new. I mean, medical masks have been around for over 100 years. We have no evidence or reason to suspect that they cause problems with alertness or chronic headaches. I mean, just think of all the doctors and nurses who end up wearing masks for hours on end while they're doing big, long operations, and they need their intense, prolonged concentration. So yeah, so wearing a mask is uncomfortable. It can make you feel hot and sweaty. Hot and sweaty is not dangerous, so don't worry. That rumor, again, tiny bit of truth at the heart of it, but it is spun out of control to be a rumor that really makes no sense. So that's my afternoon. Thanks again for having me. I'm looking forward to hearing the questions and what the other panelists have to say as well. But hopefully that gives you a little bit of idea of where we've been, what we're doing, and maybe helps out some of those myths that you've heard on the internet.
Okay, thank you so much, Dr. Bardwaj, and thanks for clarifying the masks among other things that you've managed to dispel for us. But I know Dr. Saxinger will be addressing masks in her presentation as well. So again, officially, I'd like to introduce Dr. Lenora Saxinger. She is an infectious disease specialist physician at the University of Alberta. Dr. Saxinger's role during the COVID-19 pandemic has been co-chairing the Scientific Advisory Group, which was created to apply best evidence to Alberta's pandemic response by answering questions for Alberta Health Services and public health. So Dr. Saxinger will give us some insight into how we go forward from here in this pandemic, what life will look like, and how to minimize your personal risk when taking part in everyday activities like gatherings or traveling. Again, thank you so much, everyone, for posting your questions. I am keeping track of them, and I will make sure to ask them at the very end. Dr. Saxinger, you may begin.
Sure. Just want to make sure I'm sharing the right thing. Can you guys see my slides?
Yep.
Okay, great. I covered kind of a lot of broad topics that to some extent are reflecting the questions I'm getting because I've been doing some Q&A sessions for media as well. And also some big picture thinking. I think we've come out of the intensive adrenaline-fueled phase, and now we're really trying to feel our way forward both in the medical system and actually just in the communities. And so I think that I'm trying to bring things together a bit. We've covered a lot of great territory already. So risk in the time of COVID-19, was this all some kind of crazy overreaction? I have heard people suggest that. I will say that as of yesterday, 6.6 million people have been affected. Mostly in Europe, actually, and in North America, far surpassing the numbers from the initial Chinese epidemic. And the number of new cases is continuing to rise daily across the globe. Some places it's going down, some places it's staying level, like in Ontario. Some places it's clearly still going up, and new territories are starting to encounter more infections as well. There's been close to 400,000 confirmed deaths. And when we think about that, I looked back, we passed 100,000 deaths a month ago in terms of counted deaths. And of course, that number is going to be a low estimate. And since a month ago, there's been an average of 65 plane loads of people dying daily over the last month. So there's not been an overreaction. I think that we've been actually fortunate that we had some time to plan and that it's been managed well here. And I think that if we had not done that, we might be in a very different scenario. So everyday life has clearly shifted. And frankly, this experience has been really, really hard. I think a lot of people's lives have been damaged. Beyond those who've gotten sick or died, because the isolation causes problems with health, including mental health and challenges for vulnerable people who need to access supports. I have to point out students have had their whole learning experience, their graduations and everything else radically changed from what they expected, and it's been difficult. Access to healthcare has been uncertain or confusing. People weren't sure if they were supposed to go in or how sick they had to be to go in. Clearly, there's been a loss of jobs, income, loss of childcare, and lots of challenges with elder care. So this has been a massive, massive societal upheaval. And I think one thing that this has done is made everyone start thinking about what we value. And I think that's, you know, when you, as an outcome of a shocking experience, that we should take that opportunity to learn from it. But we did flatten the curve. And it was a big win because our health system was able to care for everyone we needed to care for. We were able to get plans in place. We're still making lots of plans. And it feels like everyone's ready for this to be over. And I feel like a real downer to say it, but it's not going to be over. It's not going to be over for a long time. It's going to be a bit of a roller coaster, I suspect. In healthcare, we have to figure out how to manage ongoing needs, catch up on backlogs as well, and respond to COVID-19 if we have new surges or when we have new surges. We don't want to fall behind, and we don't want to actually worsen other health issues that are non-COVID related. Societally, we really have to figure out how to deal with education, childcare, work, socializing, because we can't leave everything on hold forever. So we're trying to define the parameters of what's safe and what's not safe. And another thing I think that's very important is travel. What will worldwide travel be looking like? Let alone travel between provinces. So these are all really big questions. Now, I'll comment that on the scientific advisory group work we've been doing, initially we were doing a lot of work that was very science and healthcare focused. Then we broadened out, we've done reviews of asymptomatic transmission, we've done reviews of masks, we've done reviews of specific treatments, we've done reviews of health system responses, and they're a heck of a lot of work, I have to say. And the questions have been changing, and our questions are starting to look more about what the plans are. So I do have to talk a little bit about battling the infodemic, because a lot of the questions that we get even from within healthcare, to me, were symptoms of the infodemic reflecting poor information that was getting spread around or misinterpreted, and it was causing stress, and it caused us to have to answer some questions. So a few red flags that the information might be fake news. Does it have a secret or a conspiracy at the heart of it? Does it make extraordinary claims like this thing that no one thought of cures it? Usually those turn out to be false, honestly. Is it entirely based on emotional testimonials? Does it use language that's very divisive, like things they don't want you to know? Most of those are meant to catch attention and get an emotional response. And if you go digging for the content, you might find a lot of bias. And so when I'm talking to anyone about this, I think it's really important to read beyond the headline, because the headline might not actually really say what is inside the article. Look at where the article came from, and before you share it, and think about whether you value a piece of information because it fits with how you think it is, or whether it's high quality information. Because one thing that we're finding is we have to challenge our assumptions all the time as we learn about this virus, because it's new. We have not had it on the planet for even a half year yet. And it is something that we have to learn about, and we cannot settle into our information and know that we are right. We have to be accepting of the need to change. So if the headline says, study shows 80% of cases are from asymptomatic carriers, what does that mean? That means you should say, well, what kind of study was this? In this case, it was a modeling study. Who was it from? It was from a pretty decent modeling group. Is this different than anything else we've heard in the field? And if so, has someone else found the same thing? Well, I've seen other estimates using similar methods from 0% from people who are asymptomatic. So 0% and 80% seems like a big spread. And then where did the report come from? And do they have a stake in having me believe this thing? In this case, it was a news media source that was pretty reputable. But I think they just were saying this study says this thing, and it became thought to be fact. And they didn't really reflect how modeling studies work, which is you take assumptions, you plug them into a model, and you try to pretend or forecast what the reality would be. But all of the information in that study was based on the information and the assumptions that they plugged into it, which have been turning out to be changing. Our assumptions are changing. So how afraid do we need to be right now? The kinds of questions I get are, is the virus weakening? There was a news report of an Italian physician who said that he thought that based on the swab results in Italy, the virus was weaker, and everyone was really happy to jump on that one. I think that that actually was an irresponsible thing for them to actually put forth, because there's a lot of other reasons for that observation, and there was no data with it whatsoever. So I thought that was an error. Is the virus mutating? So people worry about this for two reasons. They worry about it if it means that it's going to get worse. They also worry that it might mean that a vaccine won't work. And this virus so far seems to mutate at about like 10 times less than influenza vaccine viruses do. And that's good news. It means that any mutations that we're seeing are also not really in the area that we'd expect a vaccine to have an effect. So it looks like it should not make a big difference, and that we don't have to worry excessively about that. People have asked, will it go away over the summer like influenza, or could it disappear like 2004 SARS? There's a lot of stuff I could say about this, and I will if it comes up in the questions, but even if we see lower rates in the summer, that might be kind of a relative reprieve, and that would be great because we need a break. But there's actually at least an equal chance that things will get worse in the winter, because many viruses transmission are worse in the winter because it's colder and drier, which are environmental conditions that can favor viral spread, and people cluster together indoors more, which obviously is a big deal for this particular virus, which really is a fact, something that you think about risk as face-to-face, shared air time, or close contact with someone who has an infection. The final question is, will we get a vaccine and when? And I actually think the outlook is very positive for a vaccine, and I think that it'll be one of the fastest developed vaccines the world has ever seen. Well, it will be actually, for sure. The problem is that fast still has to include all of the safety testing and adequate clinical testing. And so I really wouldn't think we'd be seeing widespread vaccine usage for at least a year or two. Although I think the work that's going on right now is very impressive. So I'm optimistic that we will get through. But everyone wants to predict the future. And do we have a crystal ball? The kind of short answer there is no. If you look at the models that are published, they mostly fall into a few different scenarios. And the scenarios that I'm showing on the right of this slide basically extend over 5 years or so. And there is a suggestion that maybe we'll just see peaks and valleys for a long time, and that it would be recurring seasonally like influenza. And that's based on the idea that it'll take a long time to get herd immunity. And so we'll continue to see waves worsened by winter conditions. The second one is the idea that there could be another fall peak, which means that, and we saw this in 1918 influenza, in a lot of places, the second surge was far worse than the first one. And so I think that's one that has us nervous in the healthcare system. And then the third scenario is kind of a slow burn where it's not as much peaks and valleys, but a constant grumble of cases and a constant need for vigilance. And in fact, I would say in all of these scenarios, there's a constant need for vigilance. The other illustration is just another group's modeling of what could happen. And we really ultimately don't know. But I can tell you that we're pretty sure that it's not going to be going away, and that we're going to have continued transmission, and that the only thing that kept us from real catastrophe were those very, very tough and severe life-changing public health measures that took place. Those are what saved us. Key concepts for risk are important. So youth are less likely to be infected. Now, this is from a Spanish serosurvey, the best quality serosurvey of antibody testing that I've seen. It's a preliminary report with greater than 60,000 people. So youth and kids were less likely to be infected in that population sample, higher risk of infection in older people, and 5 to 7% in greater than 65-year-olds. And of those who are documented positive across all places, the rate of severe illness and death is highest in those over 65. Sorry, there's a typo there. So in Alberta, we've had over 6,000 cases and 146 deaths. 90% of the deaths and 35% of the hospitalizations were in those over 70. And 10% of the deaths and 47% of the hospitalizations were in those 30 to 70 in Alberta so far. So I'm going to spend just a couple moments on the concept of risk here. I think Dr. Bardwaj talked about the anxiety response driving people's, extreme or less extreme approaches to their own protection, and how now we're getting a bit more of a scholarly look at what's really needed and not needed. But in a population basis, I think it's really important for people to start wrapping their heads around the types of things that will probably float to the top in importance. And that is the number of contacts you have a day. The more people you see, the more risk you have. And that is because people can be infectious before they become sick, or they can be so minimally ill they don't really notice it. And in some models, you get a lot of protection if the population basically keeps their contacts with others outside their household bubble to less than four contacts a day, or less than 30% of the usual as possible guidance. Obviously, some people's jobs that's not even possible, but if it is possible, those types of parameters might be useful to think about. Time and space is also very important. So if you're in someone's shared airspace without a mask and you're within a meter of someone, the risk goes up the longer you're there. More than 15 minutes in some hospital studies is a suggestion that maybe that's kind of a cutoff for risk. And then there's a lot of reports of non-household contacts who shared meals seem to be at quite high risk. Singing itself, so in a congregational setting or in a choir setting about other types is also kind of a risk. And so you have to think about the time, the space, and who is there, as well as how many people are there. Two other things I've been seeing lately that are interesting are networks. And so as we try to move forward and we say that we no longer have the harsh restrictions, can we decrease our risk by choosing how we socialize? So if you pick your bubble, and your bubble is your family plus either a group of family or a neighborhood group, like people within a couple blocks, try not to socialize outside that, or your people at work, or some other group that makes sense. That if everyone stays faithful to their bubble, that actually the risk is less of spread within a larger social network. And also think about who is in your bubble, because I think that if your bubble includes, for example, people who are elderly or people who are immune compromised, that by virtue of the fact that they're at higher risk of severe infection, you would want to be very particular about the number and types of contacts that you have. And then the final other thing is that you want to make sure that everyone in your group is more or less at similar risk. And so if you are in a group and one member of your group is, grocery store cashier, that person by virtue of their job probably has higher risk. So you want to make sure that your bubble doesn't include people who are at higher risk of severe infection. So those are just ways to start thinking about it, and we're going to learn more and hopefully get more guidance. The other thing is about where do you meet, and indoors is higher risk than outdoors, but you still have to distance outdoors. Like, you can't be silly, and we should just apply those basic measures just pristinely and perfectly, because it does for sure decrease risk. On a personal level, hand washing for sure works. Gloves to me are basically silly because you can't clean them as well as your hands. People get a false sense of security and touch stuff with their gloves and don't wash their hands because they feel protected, but their gloves are potentially transmitting infection between everything they touch. Masks, we just got some better guidance from the World Health Organization that suggests that a 3-layer mask, including a polypropylene layer in the middle if possible, is a useful thing to do if you're in a high transmission area and you can't distance. And it's unclear exactly how much that helps, but I think that the times that should be looked at are when you cannot distance. And also, I think that there's potentially some value to just showing that you're trying to protect the community as well, as long as you're handling the mask properly, not touching the front, not fidgeting with it, and washing your hands a lot. And we already talked about the personal degree of risk activities. So I think this might be my last slide, but it's just kind of a bringing it all together. So everyone has their personal actions that they can take. So distancing, hand washing, masks, making choices about who you spend time with, how long you spend time, and where you spend it. And then your own messages and what you choose to do about kindness and about support and about best practices. And so I do worry that people are so sick of this, that as we come out of lockdown, that they're going to want to return to normal, and that could actually give us a very significant risk of another wave. And anytime we have another wave and we try to move to control it, there are people that are going to get sick, people that are going to die. And that could potentially be avoided. On a community level, we want to support people who are at risk or infected. I think we have to watch out for stigma. I certainly saw patients who really did everything exactly right as far as we could tell, and they still got this infection. And so I think that we have to be careful about stigmatizing people who become infected. And we have to create this space to regain our cohesiveness and togetherness and innovate and find ways to work together, exactly like this group in Rotary is doing right now. So I think that that's intensely important. And the innovation piece is something that we need to think about. How do we accomplish the things we want to accomplish? And then on the societal or policy action basis, I really think it's important to keep science and politics apart and focus on the common good and set some expectations around the fact that when we change things, it's because we're changing it as we learn. People get frustrated and they feel like things are flip-flopping or it's wiffle-waffling or why is it different here than there? And we have to accept that the epidemic is different, even within this province and across the world, and that measures might have to change as a result. And also that as we learn more, we will refine how we do things. And that doesn't mean we're changing our mind. It means that we're adapting for best practice. So I think that was all I really had to say. And so we can move to questions. I don't know what happened to the rest of my stuff.
Okay, if we can just have you exit out, Dr. Saxinger. There we go. Okay, perfect, perfect. Okay, thank you to all of our panelists for their presentations today. I did have some prepared questions, but we're getting a lot, so I want to make sure that you guys get some value out of this Q&A portion. So we're gonna go through, I know that some of the doctors have started kind of commenting in the Q&A function on the Zoom, but let's just start with, because Henry Dunfield did ask this about the percentage of deaths under 65. Dr. Saxinger, were you able to clarify that? Are we tracking the deaths by age groups and stuff like that? But we'll have to get you to unmute. So maybe we'll get all the panelists to maybe unmute right now, just so that if you wanted to jump in, yeah, exactly.
There's a lot of data being tracked in public health and in AHS about hospitalization deaths, age ranges, outbreaks. So it's all being tracked. Some of those pieces of information are public, other ones are internal more. But the degree of tracking that we have across Alberta is actually probably amongst the best in the entire country. And the death rate compared to the hospitalization rate is very low. The slide that I used had a age cutoff of 70. But it basically, most of the deaths have been in people age 70 and above. 90% of the deaths have been in those 70 and above. And the hospitalization rate, however, is still fairly high in those age 20 to 70. And so the illness can still be very severe at younger ages, and there are deaths scattered across all age ranges, but the highest burden of severe illness and death is borne by those who are over 70, unfortunately.
Okay, Dr. Williamson or Dr. Bardwaj, did you guys want to comment on that at all?
I would say that the only other thing that I would look at is that death is not the only outcome with this virus. A lot of people end up surviving this virus, but then having huge problems with kidneys or lung function or some sort of post-inflammatory problem like kids get sometimes. So we can't just say, died, didn't die. There's a lot of things in between.
Okay. No, good point. On that note, there was a question from Henry Popoff, sorry. Are the current safety precautions for the plus 70 healthy demographic different from those of the healthy younger demographic? And if they are, how do they differ? I know Dr. Williamson, you wanted to jump in on that first.
I was actually hoping that that Dr. Saxinger or Dr. Bardwaj would do it, but
there's something very new actually right now, which is World Health Organization updated their mask advice, and now they're more specific. So in those who are over 65 or have medical comorbidities, they're making a stronger masking recommendation, and that actually specifically mentions using surgical masks over cloth masks in those groups. Now, how you have that happen, I think, is something we're going to start having to work our way through. But that is actually something that has shifted. And so until now, it has been, if you are potentially at higher risk because of your age or medical conditions, that you should do all those things only more carefully even. Now I think it's become a little more specific, and we're going to have to be looking in that World Health Organization guidance and figuring out how it's going to actually happen, to be honest.
if you guys, gentlemen, if you wanted to weigh in, you can as well.
The only other thing I would add is that age itself is a risk factor. Whether you're a healthy 70-year-old or not, your immune system is different at 70 than it is at 20. So that itself becomes sort of a factor.
Okay.
Actually, the AHS data is pulling apart people who by age and comorbidities, and so we'll probably have some local extra information on that too. It's an interesting analysis, and I mean that's been the case that age alone, but age plus diabetes or hypertension or other issues are kind of a double whammy, triple whammy.
This was a question that was posed during Dr. Williamson's presentation. I know that you had mentioned something in that little function, but maybe for everybody else. This was causing the cyclic increases and decreases in the number of daily new cases. This is from Brian Carnahan.
Go ahead, Lenore. Yeah.
One of the things that we saw early on is that you get these big dips in the graphs, and part of that was because for a period of time the lab was running out of reagents, and so they'd have to hold all the tests until they got a new shipment, and the lab was like begging, borrowing, and bribing, as far as I could tell, to get material to run the tests. And so while they were still ramping up, and I got to say that at one point Alberta had Alberta alone was testing as much as 20% of the entire United States at one point. Because I remember looking at the numbers and going, whoa, we're doing really well. Yeah. But there were some peaks and valleys related to testing and assessment centers and backups in the lab. And then, some of that noise, actually, you really kind of want to look at the graph and imagine it as a smoother line for trend and not pay attention to the zigzags too much, because they probably don't mean that much.
I'll just add, and I think it's super important that as we continue to monitor how many new cases we have, that we put that in the context of while testing remains high, right? Because we can't say, oh, we've reduced our amount. We have, and Dr. Saxinger just mentioned, I mean, Alberta leads the country, almost 5%, or in fact, actually now more than 5% of Albertans have had a COVID test done. We've done 52 out of every 1,000 people. Which is remarkable, hundreds of thousands of tests. And so while the testing is high, we can be more confident in, what new case numbers actually mean, and that there is a reduction or an increase in cases.
Okay. This is from Franco Savoia. I hope I'm saying that name right. What do you recommend that we all need to continue to do to contain the virus?
I think mine kind of covered some of that. I think it really comes down to, no matter what the current state of public health emergency is, we change the way we operate on a daily basis and start with really pristine fundamentals around hand washing before and after you leave the house, distancing, masking in the recommended way in the right setting, and being really thoughtful about how to maximize your, social connectivity within a lower number of contacts, of higher quality contacts and different quality contacts. Because at the end of the day, anytime your network links with another network, everyone in both networks is actually potentially at higher risk. And as a society, if we pay attention to those things, coming out of lockdown will be much more effective and safer. And then the other thing I think I should mention is, because we have a lot of testing availability, the barrier for which you think you might need to be tested, you should keep that pretty low. If you've had exposures that you're worried about, or if you have symptoms, as long as we have the capacity, the testing actually does let us keep an idea of what's going on. And our percent positivity, the test is really low right now, and that's great. That means we're testing a lot and not finding a lot of cases. That's exactly where we need to be. Comparison, there's lots of jurisdictions that have 5 to 10% of their tests are positive, and they're counting that as a victory. Ours has been consistently under 1% for the last few weeks, and that's exactly where we need to keep it, because we know there's going to be some transmission. We just want to make sure it's not happening in places that we're not seeing it, if that makes sense.
Yeah, and thanks for reiterating all that again. I am just, go ahead, Dr.
It's okay, we can move on. It's totally fine. Let's move on.
Oh, I have a question. I have a question.
Okay.
I have a question for Dr. Saxinger related to testing and getting tested. If, for example, somebody said, okay, this weekend, we're going to go visit with grandparents or something like that in another town, would it be a good idea to go and get tested on the Tuesday or Wednesday before that, knowing sort of so that you know you're negative before you take off on this short and isolated trip, I would say?
I think that that's a consideration. I think that the problem with the whole concept of the asymptomatic spread is that all the studies are horribly flawed, and the better ones suggest that maybe 15 to 20%, a new one that I haven't reviewed yet said up to 40% of cases might be asymptomatic. Asymptomatic people don't seem to be as good as transmitting, but it's certainly possible. And so I think that there's some value in that, just recognizing that any single test can be a false negative. But if you feel very well and you've had a recent negative test, I think that that might make you feel a little safer if you're, going to visit someone at risk. But you'd still want to do all the other things because, of course, infection could start at any time. And just before you get symptoms is when you're actually the most infectious. And so it's a slippery concept, but I think there's some value in that, but you would never actually rely on it.
Yeah, it's kind of like masks, where you can't rely on masks to make, you can't put a mask on and think this is my cape, my shield. I'm going to go out and do whatever I want now. You still have to physically distance. You still have to wash your hands, like crazy, really. You still have to do all those other right things, not share food, not sit inside for a long time across from somebody sharing a meal, not go to buffets if those will ever exist again, things like that.
Yeah, buffets are very questionable. You know what, Kathy, I see three that are kind of related that I could run through super quick.
Yeah, why don't you do that? Yeah,
I'm just trying to testing.
Track of ones coming in and the ones that I've written down. So.
Yeah, so the ones that are about testing is how soon after exposure will a test be positive? Out to, it could be up to 14 days. The vast majority of people would develop symptoms within 14 days. On average, it's 4 to 5 days. If someone was in a crowd, how quickly could they become positive? Usually you would, like I said, develop symptoms at 4 to 5 days. Your test might become positive at 2 to 3 days, but it could also be false negative at that point. So if you have a high risk exposure and a single test negative, you'd want to get another test. The reliable antibody test, we have 2 platforms that the lab is evaluating right now in Alberta, and it's similar in other places in Canada. Some of the tests that have been marketed are terrible, like they're really bad. The ones that they're looking at that are good, both are ones that you can do a lot of them in a central lab setting. They're not the little finger stick ones that you do on site, because the lab ones are actually much more reliable. And I expect that we'll have availability of that soon, like weeks. I saw one other one's on testing, but now I can't see it. So I think I'll stop there.
In terms of getting reinfected, what does the best research suggest about that? Do we know?
Yeah, I just did this review for scientific advisory group. As far as we can tell, any publication of reinfection has been related to the fact that after infection, people can actually shed little bits of dead virus in their chest secretions and in their saliva for out to 4 to 6 weeks. So that's, it can be a really long time that you can detect viral fragments. But when they try to grow the virus, that's no longer viable virus. And so if you have a whole bunch of virus in your chest, you're infected, you get better, you're still getting better, and someone does a test and it's negative, and then someone does the test again and it's positive, the most likely explanation is that the amount of virus fragments that they're detecting is just hovering around where the test can actually find it. And so you just happen to pick up a positive, negative, because you're just around the border where the test can pick it up. It's a very small amount. There's been no well-documented examples of people actually getting reinfected yet. And we don't know how long the immunity after infection would last. So stay tuned on that. But that big question about, oh no, they tested positive again, so far that all seems to be just shedding of dead virus that went on for a long time.
Right. Okay. That's good to know. Thank you for that. In terms of the current view on herd immunity, is it certain that this can or will happen? Do we know at this point?
I could take that one too, but if you guys want to jump in, go ahead. Because we just keep on reviewing these again and again in scientific advisory, and it looks like you can get a neutralizing antibody response, and that natural infection should protect you at least for a period of time. And in the places that have been very hard hit, where they've done population-based antibody studies that seem to be pretty decent, like the one I mentioned in my slides from Spain, the numbers that we're getting across a country are around 5% of the population has been infected so far. And that's in the setting where they had an absolutely devastating healthcare system crushing epidemic and an outrageous number of deaths. And in New York and in some other focal city areas where there was really big epidemics, the numbers might be creeping up to 10 or 20% of people have been infected. But the number that you need to get herd immunity is likely in the 60 to 70% plus range. So even in the worst hit areas where it's been absolutely devastating, we're nowhere near herd immunity yet. And I think that that tells us that the cost of going for herd immunity is likely not really something that we should do, that we should try to just keep things at bay until we have a vaccine, because otherwise there's excess death.
I'll just add to that. Thanks, Laura. There's also lots that we're still learning about the virus, and you know, I mean, it's clear. I would say that it's clear that, you know, our hypotheses around who is susceptible, all of these types of things are maybe still open questions. You know, if the virus had run rampant through the population like we expected it would in April, you know, we would have had many more cases. There's lots of places where it has really taken a strong foothold, and there's lots of evidence that, you know, our population control measures, you know, social distancing, things like that, have made a big difference. But there's still lots that we don't know about the virus, that we're still learning. And so, you know, we definitely want to get to a state of herd immunity. That's why we want a vaccine, because that's what it'll give us. But you know, just sort of exposing people, as Dr. Saxon just said, it's just way too risky at this point to just say, let everybody go and hope that, you know, we don't have too many deaths.
The other thing that I could add to that is this idea that, you know, once you've had it, again, you're completely immune, and you can go and do whatever you want and sit close to people and not wash your hands and, you know, walk through the grocery store like you're Superman. That's not true. And we don't know the strength of the immunity or the length of the immunity, like Dr. Saxinger was saying. So at this point, there's just so much we don't know yet. And we really are learning all about this virus in real time, day to day.
Every day.
For sure. Sorry, Dr. Williamson, did you want to say something?
Nope, that's all. Thank you.
So the other thing that makes this virus so complicated is, of course, the asymptomatic cases, right? So you can, you know, carry on with your life, have it, but not exude any symptoms. So there is a question about any theories as to why there are so many asymptomatic cases with this particular virus.
I think, for one thing, we don't really know the number, and the reported number varies widely, and is probably more in the 15% range than higher than that. And again, when people are asymptomatic, they're not coughing and sneezing, their nose isn't running, so they're a little less likely to transmit it. So that would mean that asymptomatic people are probably mostly a risk to the people that they're most close to, if that makes sense. So walking by someone who's asymptomatic, if they're not coughing, sneezing, have just rubbed their nose and grabbed the doorknob, is unlikely to spread the virus. The virus still has to get from one person to another. And I think it just reflects that there's always been a spectrum of illness that people can have. But the thing that makes this particular virus really difficult to control is that, unlike similar related viruses, other coronaviruses, it actually gets to really high levels in the upper aerodigestive tract, so the nose, mouth, throat, upper chest secretions, really early in the course of the infection. And so the people who are carrying it in a way that makes it more spreadable very early, versus SARS 2003, where it concentrated deep in the lungs later in infection. And so it is just more transmissible, even with milder infections. And I think that every infection, there's some people who get it worse than others. In this case, the problem is that people who have very mild disease can still spread it. It's a very strange virus, really.
It is. And I think the question was more around, like, why is this one? Why are so many people have asymptomatics?
We don't look for that usually. Like, we don't know how many people have asymptomatic anything, because we usually are not trying to test full population.
Right.
So it's just a completely different area to be in, to even be talking about asymptomatic spread compared to a lot of other things. And the other thing is, a lot of the studies that talked about asymptomatic, we didn't yet know that you can shed it for so long. And so some of those people could have had a cold 2 weeks ago. they're asymptomatic and they're tested and they find the virus, that doesn't mean that they're asymptomatic carriers. That means that they had a cold 2 weeks ago from COVID. And that's what that was. And so a lot of the studies are really flawed on definitions. So stay tuned, because I think we're trying to hone in on what really is the proportion of asymptomatic. And some of the Alberta data actually might be useful in that eventually too.
For sure. There was a question in the Q&A box here just about, like we've done a pretty good job here in Alberta flattening the curve. What about, cases in Ontario and Quebec? We've seen those numbers are just so big. That's a question from a guest here. Can you give us some insight into that?
Tyler's wheeling away, so I'll talk till he's back. I think that there's a really complex scenario in Ontario right now, and they've got a really difficult system in terms of trying to control things, in terms of coordinating responses between public health units and levels, in terms of test capacity. And I think that that's been a real struggle for them. There's just so many different levels that they're trying to work across. And one of the things that I think has been a strength for us is that Alberta Health Services and Alberta Health have gone through all this already when we became Alberta Health Services and Alberta Health. And we actually have good lines of command and a clear sight. And we had provincial groups coming together at the right level immediately. And that kind of coordination it seems super boring because it's really all about meetings, but it's incredibly important. And I think that the other thing is they kind of reached a certain stage of community-based spread in a very large city, like really mostly in Toronto, where it's really hard to turn it around unless you can quarantine people differently. And that's been a real challenge. So they have a few different things working against them though. And the same thing was happening in Quebec, although it's getting better there. It's pretty alarming, honestly.
The other thing that I would add to that is that Quebec, they have a different spring break. I know there's been lots of information about this. And so they had a lot of travel very early in the, what became the pandemic, before it was as widespread as it. And so both Quebec and Ontario had a huge number of imported cases brought into the province from outside, from either the US or other international travel. That's been one really big thing. And Ontario was very late to the testing game. We in Alberta, we got out ahead of the testing, and Lenore already said it. We were third in the world for a good while in testing. And that's amazing. And so Ontario was way behind. They had huge positivity rates. And I think that they're still paying the price from not getting ahead of it like we did in Alberta.
For sure. This is a question, or I don't know if Dr. Bardwaj wanted to add to that at all.
No, I'm good. The only thing I would say is that in a pandemic, when you're talking about exponential growth of infections, the best thing to do is to do things early. And if you even delaying a week or two or even days can make a huge difference in terms of numbers of tests. So things like our spring break being later than Quebec's made a huge difference. So we were pretty lucky.
Unlocking all of this. Yep.
Definitely. Hopefully we can continue that trend. This is for, we have a couple questions for people 70 and over again. This person is asking, if you're 70 plus, you lived a life where you perhaps suffered a couple of different ailments, but you know what, you got past it, your immune system's stronger. Does that give you a strong, I guess not an immunity, but a better fighting chance if, let's say, you were to contract COVID-19, or does it not matter at all?
Raj?
Sure, I'll start with a couple of things. So one idea is that some infections in the past or some experience in the past maybe will help you fight off this infection, but this is a novel virus. This is a brand new virus. So, the fact that you got your flu vaccine, I'm really glad you did get your flu vaccine every year, but unfortunately that's not going to help your body to recognize or fight this virus. Having fought off other things in your life doesn't mean that unfortunately doesn't mean that you'll be able to fight this off necessarily better than if you didn't have those experiences. Dr.
For sure.
I think that there is just clearly a problem that as you age, as has been mentioned, your immune system is less able, and you might not have as much kind of surge capacity when you have a serious illness, even if you're starting very fit. And so I think you'd have to look at age as being an independent risk factor, even if otherwise you're in very good shape. And as mentioned, none of us have any pre-existing immunity to this virus. The entire world is susceptible to it. And so it's unlikely that previous experiences will help the way it does with flu. Like with flu, if you always get your flu shot and you've had influenza a few times, your kind of archived immunity does help you in the long term, but we don't have that with this yet. Maybe someday this will be like a flu, and it will not be as devastating in our population, especially if we get a vaccine. But at the moment, we're all at risk, actually.
For sure. Speaking of the risk and diminishing the risk, the recommendation is a 2-meter distance apart, 6 feet apart. I have a question about how scientifically accurate is that recommendation of staying 2 meters apart and, you know, diminishing your exposure. Of course, it differentiates if you're wearing a mask for sure, but just like, you know, where did that distance come from?
I've been asked this one before, so I can take a crack at it first.
Yeah, sure. You go first.
That cleanup, or no?
No, you go ahead. Yep.
Because there's two things. The 2-meter distance is actually predicated on both droplet theory, where most droplets of the size that we think carry this virus fall between 1 to 2 meters away from the source patient. And that's been borne out in studies with similar viruses that spread a similar way, like influenza. There was a study I remember where they actually had influenza patients and they were looking for viral detection in the air. And they found virus about 1.7 meters away from the coughing inpatient. And thus they said that for healthcare workers, 2 meters looks like a good distance. Then there's also been some study, meta-analysis just published in Lancet where they looked at the distance. And I'll just say from all the studies there are, which are not fantastic, but they're not terrible and they're not nothing. The safe distance really is 1 to 2 meters with a bit of a improvement in safety towards 2 meters. And so it's not made up, it's real, and it actually does make a difference.
Okay, we good on that? We good on that? Okay. Have another question about, because we know that right across the country, actually, it's been devastating in long-term care facilities. There have been lots of seniors dying. This question is about, has there been a difference in outcome for patients plus 70 years that have received hospital care versus in a place like a long-term care facility? I'm assuming this person's, well, I'd like to think that if someone contracted COVID-19, they would go to the hospital right away, or is that not it? That they would try to you know, take care of them in long-term care facility first. I don't know if someone can answer that. And
I think that's a difficult one because people who are over 70, for example, and live in a long-term care facility, there's two issues. One is that their health is frail enough, maybe, that they have ended up in a long-term care community. So that maybe differentiates them right away from people who are 70 and not living in a long-term care community. And then the other thing is if you live in a long-term care facility, that is a densely packed, potentially, you know, a place where infection can spread potentially very quickly. So maybe that itself is a little bit of a risk factor.
okay.
And I would say that one thing we've observed is that, I mean, when people need to go to the hospital, they get sent to the hospital, and if it is in keeping with their overall philosophy of care, and not all people in homes have a care plan that involves hospital transfer. And I know that there are some long-term care settings where they've tried to provide as much supportive care and antibiotics if they seem to be needed and all those things. And so I don't think there's much difference, except it might start to vary if people need a lot of extra oxygen support. And in that case, again, it depends on whether the individual's care plan involves going into a hospital setting or more aggressive resuscitation. And so I think that they provide the care that they can provide in the site, and they have, you know, good plans for doing that. But at a certain point, there has to be a decision whether this is something that's appropriate for a hospital, if that's in keeping with the patient's wishes. And certainly there's been quite a few of the deaths have been observed outside hospital where people are kept home. And that's presumably part of what they wanted to happen. That's mostly in people who are very elderly though, not necessarily the younger population.
Okay, thank you. Let's move on to some food. There's food-related questions here. The first one is, there's a question about whether or not we need to clean our groceries after we come back from the store. I know there are some people I know who do that. I certainly don't. Is that recommended?
There was that video of this crazy guy washing his groceries with soap. And I think that he's made everyone's food taste bad for a long time for no reason. Because the only way you'd get virus from your groceries is if someone who is infected contaminated their hands fairly heavily, touched your food, then you touched it, and then you rubbed your eyes or licked your fingers or did something to your face to inoculate yourself. And so the whole thing about packages and food to me is that's a very low risk to start with. But if you want to deal with that risk, you just make sure that you wash your hands after handling things. And the virus couldn't withstand cooking or anything, so that's not a concern. So like really attentive hand washing after you handle things from outside should actually do very well to protect you. And washing your food with soap is particularly difficult if it's like food that has nooks and crannies and ends up tasting soapy. It's quite unpleasant. So I'm an ID doc and I don't do that.
Right, that's good to know. So Canadian Food Guide came out with a recent review. So this question is, to what extent should public health initiative focus on public nutrition, as in like to the extent that nutrition may pertain to minimizing the acute symptoms of COVID-19? Is there a link at all? I mean, obviously, like a healthier, like if you're healthy and you're young, then, like that would help. But is there any direct link to eating certain foods or, having a certain, particular lifestyle when it comes to nutrition?
Not that I know of.
Raj, didn't you tweet about this some time ago about how don't be fooled into thinking that by somehow eating some special food you can become immune from COVID? Maybe I'm recalling that incorrectly, but either way, the point is the same. That obviously eating nutritious food and all of those things is good for you, but to be clear that it's not like if you went and doubled down on your carrot intake tomorrow that you would all of a sudden become no longer susceptible to COVID. That would be false.
Yeah, absolutely. And there are always rumors that come out whenever there's an important, infection or important disease or anything, where people say, oh, but if you just take vitamin C or vitamin D or, antioxidants or this or that's going to be the cure-all or the prevent-all. And I think that people generally do look for simple answers to complex problems. And COVID is a very complex problem. And unfortunately, there are no quick, simple answers. I mean, the simplest answer that we can tell you is, do those things. Wash your hands, stay 2 meters apart. Assess your risk when it comes to respiratory droplets, whether, you're getting exposed directly through respiratory droplets or respiratory droplets that have ended up on surfaces, and then you go and touch those surfaces like groceries or mail packages or whatever. But yeah, there's no easy answers, and certainly there's no basis for thinking that there will be easy answers when it comes to certain types of foods.
Okay, so on that note, there was a question I just want to quickly read. I think we know the answer, but just to say one more time, someone read a paper that stated a fairly large number of patients who died from COVID-19 had negligible vitamin D levels. Just based on what you said, there's no link, right? Or it's hard to say at this point.
There's some studies right now for vitamin D. There's been a long, complex history of vitamin D and immune function and some suggestive observational data that makes it a valid question, but there's never been a really excellent answer suggesting that it might not just be that people get sick and that causes their test results to change, or that people who come from a less privileged background who might be more likely to have low vitamin D are more likely to get sick. So teasing all that apart is important. And there are some studies going on right now looking at the role of vitamin D supplementation in other kind of questions of this nature. Vitamin D supplementation doesn't seem to make a difference to some of the diseases that we've wondered about. Having said that, because we're in the Northern Hemisphere and because summer is short, I usually just tell everyone to take a vitamin D supplement anyway. And that doesn't seem like a bad thing to do, but I don't suggest super supplementing, and I don't necessarily think that you'd imagine it would protect you for sure. But there are some studies looking at it, and vitamin D has kind of specifically been one of the areas of more active questioning in immune type diseases.
Okay.
And we also know from a family health point of view, or family medicine point of view, that people who are more frail tend to go outside less. And when you go outside less, you get less sunshine, so your vitamin D levels start to drop. So there's certainly a correlation between low vitamin D levels and frailty, which then can lead to, worse outcomes when you get an infection or end up in hospital. But as scientists love to say, correlation is not the same as causation, right? It's not cause effect necessarily. So yeah, this is the problem, I guess, with science, is that science takes, good science takes time. And to do science with regards to things like vitamin D levels and COVID survivability or survival is going to take a lot of time.
Okay, thank you. So we have less than 5 minutes left. There are so many other questions, but I'm going to try to maybe ask two more general ones. So my first one is, this is from a guest. I want to see my 92-year-old father or whatever. So can we do that? And if we do, what should we do? Can I only see them from outside through the window, or can I go, as long as I keep the 2-meter distance? Like, what are your guys' recommendations for that? Because as the economy starts to reopen, people are going to want to see, their loved ones.
And can I hug my grandkids again? Raj, do you want to take this one?
Yeah, exactly.
Yeah, I mean, this is a really tough one, and something that, again, I've tweeted about, because this idea of sort of more humanistic guidelines of what can we do, and can I hug my grandkids, and can I go visit my 92-year-old grandfather or whatever, those are all things that the government's not going to necessarily come out with guidelines about, like how to open a restaurant or how to open a hair salon or something. And I think it's one of those things where, we're moving into a world where risk is a real thing, and every thing that we do, we will have to think about how do we manage the risk around that. So there are some answers that we have, and there are some answers that we absolutely don't have. And so that's going to leave sort of this lingering bad taste in your mouth, where I say at the end of this, I can't tell you what to do, but I can tell you that being outside seems to give a lower risk than being inside, like Dr. Saxinger said. Spending a long time with somebody gives a higher risk than spending a short time with somebody, like Dr. Saxinger said. Washing your hands and not, being close together and sharing things like food and things like that will lower your risk. But, can you go visit your 92-year-old? It depends on a lot of things, and it depends on how you go and visit them. So yeah, do you have to visit them through a window? Probably not. You probably, meet outside and sit apart from each other and have a really good in-person conversation rather than over FaceTime or something like that. But can you sit down and have a 1-hour meal with them, or invite them over for a family dinner where you're all sitting inside and, serving from communal plates? That's a lot higher risk.
Agree. I think, a lot of what was just said and a lot of what I sort of sketched out in the slides have to do with this idea of how much risk can you accept. And when you're looking at someone who's 92, the other thing to think about is, okay, so if the odds are low that you might transmit infection, that's one thing, but what are the consequences if you do transmit infection? And that could be very devastating. And so I think we have to recognize we're not going to operate in a zero risk scenario. There's always going to be some risk. And you just have to kind of find a way that seems reasonable. So if you take all the precautions that we know about right now, and you think that, if someone is 92, they might not have that much more time, and they might be willing to say that risk is fine. If we do everything as well as we can, that risk is fine. And I think that is actually an acceptable answer. But I would not then say, just do anything you want. I think that would be a mistake. So it's hard, and we get a lot of these questions, and I think it depends on your risk tolerance, and just start at the basic principles and then do the thought experiment, what if, and see if it's acceptable to everyone.
And the consequences to others too, right? If that's my 92-year-old grandmother and she's in a long-term care facility, where I'm worried about taking it into that facility, that's a whole nother layer that you need to consider in all of this as well, right? So great points though.
Okay, it is 2:46, folks. So that concludes the first panel. I'd like to thank everyone for attending and for listening in and for all your insightful and thoughtful questions. I'd like to thank Dr. Williamson, Dr. Barjward, and Dr. Saxinger for your presentation and for answering the questions. There were many questions and there are many more. Do you know where people can go for, I guess, the most credible answers if they have anything further to this panel, because I'm sure that's what people are going to want to know. Where should they go?
There's a lot of different resources, and I think starting with the Alberta resource pages or your local public health pages often have a lot of really good links. And then, reputable news groups often have really great articles addressing risk. And I would actually suggest going there directly rather than going through someone else's Facebook feed or other, because there you get a lot of biases introduced. I don't think that there's like one single common awesome source of all of this information, because it changes so quickly. But if you make your list of your top sources that are straight from the source, that's a good place to start.
Okay. Well, there you have it. I'm sure we're leaving this panel with a bit more clarity to keep ourselves safe and healthy. So again, I'd like to thank all of you for joining me today, and for everybody else who's joined in. We have lots of other things fun for today, including some events, some awards, some presentations, and also another panel. So that's where I will leave it. I will allow Christine now to take it away.
Wow, wow, wow. Thank you so much. Thank you so much for taking the time to share with us. The questions were piling in. Man, I was so impressed. And thank you, Kathy Lee, for moderating. And I would be remiss if I didn't say that Kathy is a dedicated Rotarian as well with the Heritage Park Club. And so thanks again. And I feel blessed to have had you here today. So take care, stay safe.
Thank you.
Moving on, we're going to take a few minutes of screech and stretch break. And so get up, get a bathroom break, move around, do a stretch, and grab a bevy, and we'll see you in 5 minutes.
Christine, you are muted.
Yeah, I'm just unmuting. Thank you. Welcome back, everybody. Wow, what a fantastic first panel. I've learned a lot, and you know what? I feel a lot better. So I'm hoping you do too. We are going to do some awards right now, the Rotary International Awards and our district awards. Very, very pleased to be presenting today awards to, we'll be having them up on the screen. So when they're ready to present, I will commence with the district awards. Great. Thanks, Charlie. So these awards are being presented, first of all, the Rotary International Awards will be presented firstly, the Rotary Foundation Citation for Meritorious Service. And this award honors members who have been actively involved in service related to the Rotary Foundation. And this year's recipient is Gail Williams. Gail has been tremendous in Rotary service over the years. We're proud to recognize her. And Gail, your award is on your doorstep, I believe. We did get it to you soon enough. And but this is the certificate for that. The next is a Rotary Foundation's District Service Award. Very proud to present this award that honors Rotarians in our district who are making a difference through the Foundation's programs. The award is given this year to Hendrik Craig, Calgary Olympic, for outstanding service in promoting the Rotary Foundation, to the peace programs and scholars that Hendrik has been a part of for many, many years. So I'm really happy to recognize him today. Moving into our Rotary District 5360 Awards, I'm very honored today to present this. It means a lot to me, this award. This is our beloved Monty Audenart Inspirational Award. Monty, when I first joined Rotary, was district governor the next year and really impressed me. He made it all the way to our Rotary International Board of Directors, and sadly he passed away a few years ago. So we have an award recognizing individuals who are inspiring and demonstrate outstanding achievement in Rotary and the community locally and internationally. And we have selected this year past District Governor Pat Kaloran in Lethbridge. And Pat, we have this beautiful sculpture was going to go out to you. It's on the way in the mail, and I'm really proud to honor Pat with this award today. Pat also has a Blackfoot name bestowed upon him, and he's honorary chief of the Blood Tribe. So congratulations, Pat. The Rotary District Awards continues with the Glenn Peacock Award for Outstanding Rotary Club. This award is for large, medium, and small clubs that best reflect the themes of Rotary International and the district. Presenting award goes to the first club, the small club, for Brooks. Congratulations, Brooks, for demonstrating Rotary's theme of connecting community. Rotary Connects the World. They actually received an award for an inclusion award from their city, and so congratulations, Brooks. The medium award goes, medium-sized club award is presented to the Rotary Club of High River. And thank you, High River. During this last while, you have been showing exemplary community connections, and again, this is recognizing the tribute to you and your community. The large award goes to the Rotary Club at Stampede, Calgary at Stampede Park. This club has shown and demonstrated for many, many years its community connection and how it has connected the world through its relationship with the Stampede Board and the annual Calgary Stampede. Sadly, we had to postpone it this year, but you know what? We can come back from this. Congratulations, Calgary at Stampede Park. The Mel Cunningham Club Publicity Award is for the best club's public relation activity that promotes Rotary in their community. So the club, the recipient is the Stetler Club for the Mel Cunningham Publicity Award this year. Congratulations, Stetler. You have a well-deserved award. Excuse me, award. When I was there on my visit, I was blown away by the number of projects and how much you do for the community. The James Wheeler Davidson Membership Award is presented to the Rotary Club with the greatest percentage net increase in new members. And it's this year, I'm proud to say, it's the Rotary Club of Cochrane with 59% increase in members generated by the establishment of a satellite club. Is the recipient for this today. Congratulations, Rotary Club of Cochrane. The George Curley Galbraith Club Attendance Award is for the club with the highest attendance at district conference. I'm proud to say the Rotary Club of Calgary Downtown has the highest attendance at this conference this year. Congratulations, Calgary Downtown. The Gilbert Patterson Rotary Foundation contribution is for the club with the highest percentage, sorry, let me just rephrase that. The highest per capita year-to-date contributions to the Rotary Annual Fund. The club receiving this year, Calgary Fish Creek. Thank you for contributing to the annual foundation at such levels. The Ryerson Christie Conference Attendance Award goes to the club with the highest percentage. And here we have Calgary Fish Creek has the highest percentage of their club membership attending our conference this year. Thank you for your support. Right now we're going to move into the Shelter Box of Canada Hero Awards. There's 3 levels. And, oh, sorry, I meant to say the honorable mentions for the other clubs. Sylvan Lake and Calgary Centennial are also honorable mentions for their per capita contributions. Sorry about that step. Be the Hero recognizes clubs who have been supporting at Shelter Box with their annual contributions. There are 3 categories: bronze, silver, and gold. The recipients this year for these awards are, for bronze, Calgary Sarcee, Calgary Heritage Park, Lethbridge Sunrise, Lacombe Daybreak, Red Deer East, Rotaract United, and Stepper. For silver, Medicine Hat Samos, Calgary North. And for gold, Calgary Fish Creek, Calgary at Stampede Park, District 5360, Rotary Youth Exchange. Thank you all for contributing to the Shelter Box, making a difference in the world. The next awards are a special tribute in memory of past District Governor 2010-2011, Al Bergsma. Shirley, Al's widow, has graciously donated the accumulated points from donations made by Al and Shirley to the Rotary Foundation. Shirley's desire was to recognize youth in some way, and boy, do we ever have a way. The recipients today represent Interact High School Rotary, Rotaract College and University Rotary, past youth exchange participants called Rotex, and RILA, Rotary Youth Leadership Awards. These young leaders have exemplified Rotary and its motto, service above self. Our Rotary future looks bright and strong with these amazing young leaders. I am thrilled to present Paul Harris Fellowships to the following. First name, there's Al's picture. Megan Day. Megan is a Rotex, and she has been our senior lead, helping the exchange students inbound and outbound for the last while, and congratulations, Megan. Taylor Fulton, past exchange student and president of the Rotaract Club of Lethbridge. Taylor's passion holds no bounds, and we're so proud to present you, Taylor, with this award today. Khalid Khashoggi. Khalid has been the leader of the Rotary Youth Leadership Awards camps, run every year for several years now, and he is an outstanding leader, and we're so proud that you are continuing with this. Thank you, Khalid. Maya Povey. Maya is a past exchange student, and it was just announced that she has established a Rotex Alumni Association, which was just approved, and congratulations, Maya, for this. Thank you so much. Aaron Verhesa. Aaron is president of the Interact Club of one of the old schools, high schools, and he has been outstanding, and his name was given to us as nominated as an outstanding Interact president. And thank you, Aaron, for your community service. And Justine Wild. Justine is District Rotaract Committee Chair, and she is the first Rotaract to sit as a director on our district board. Congratulations, Justine, well deserved. Okay, the next 5, well, it's already one's up, have been so engaged with communicating, connecting, and collaborating with the Interact clubs across our district, and they are critical to preparing and launching this webinar as part of our district administrator, Charlene Bearden's team. I am so proud of them. Camille Cantor. Camille is Interact co-president of the Western High School, Calgary. Thank you, Camille. Jarvi Cha. Jarvi is also co-president of the Western High School in Calgary, and I thank you, Jarvi, for your service. Iba Syed. Iba was the first Interact representative to sit on our Youth Services Committee, and she is now in Rotaract at University of Calgary. Thank you, Hiba, for your dedication to Rotary. Rebecca Supriya. Rebecca, thank you so much. Your talent is incredible. Rebecca was responsible for making these beautiful posters for our conference, and her commitment to Interact has been incredible. Rebecca is with the Lethbridge Interact High School Club. Thank you, Rebecca, for your service. Itmak Ioli. Itma is president of the Interact Medicine Hat Club. She has been so committed to working with Interact all year, helping with forums and presentations, and a big part of who we'd like to celebrate with this Paul Harris Fellowship Award. Thank you, Itma. Okay, thank you to all clubs and members for continuing to be people of action for all of the world. So now we will move into our next session, and we're going to have a welcome by a surprise guest singer.
Hello Rotarians, Paul Brandt here. I understand that you've renamed your conference to Rotary Crushes the Curve. Thank you for all of the good work you're doing to combat COVID-19 and make a difference in the lives of others. I applaud your ongoing work around the world to provide humanitarian service and advance goodwill and peace. Collectively, your efforts are making a difference to making lasting change for those who are vulnerable. You don't just talk about what could be, you go out and make it happen. Thank you for being willing to work together and make a difference. I hope you're enjoying the conference, and while it might not look the same way that you'd planned, no doubt the ideas you're gathering and sharing will continue to make a positive impact locally and around the world. Thank you for all that you do. All the best.
For the next panel, I'll introduce you to Drew Kessler. Drew is Vice President and Relationship Manager of the Commercial Real Estate Division for M&T Bank. A Rotarian since 2001, at the tender age of 20, Kessler has served the North Rockland Rotary Club in all levels of leadership and became the youngest president in their 91-year history at the age of 25. Drew is past District Governor of Rotary District 7210. Currently, Drew serves as the General Chair for the Mid-Northeast President-elect Training and zones 28 and 32, and for people who aren't Rotarians, that's our Rotary zones for all of Canada and northeastern United States right now. Rotary is an organization that fosters and encourages the idea of service in both the local and worldwide community. Drew lives by the motto, service above self. Drew resides in Hopewell Junction, New York, with his wife Vicki and their 5 children, Dylan, Joe, Parker, Jackson, and Brandon. So please welcome Drew Kessler today. Thank you, Drew.
Thank you, Christine, for that warm welcome and introduction. I come to you from, unfortunately, the epicenter of North America, as I live in New York. I'm about 50 miles north of New York City, so this has been very very trying couple months and experience for all of us, but specifically in the region that I'm in. Christine asked me a couple years ago to attend your conference that was due to take place the beginning of May, but unfortunately the current situation did not allow for that. And obviously I am very happy that I'm able to join in some capacity in being the moderator for this panel. Her goal then was to have me share stories of Rotarians that were people of action. And with every challenging situation like the one we are currently experiencing, there are those who step forward and do amazing things. This is an opportunity for our organization and our Rotarians to show the world we are people of action. This panel focuses on panelists that are stepping up and demonstrating what people of action are all about. As with the last panel, each panelist will share their information, followed by a question and answer opportunity. We begin with Jerry Darashuk from the Rotary Club of Calgary North. Jerry is now retired, but spent his career in manufacturing since the age of 19. Everything from manufacturing polymers to printing and packaging to bottle distribution. He is the ultimate capitalist who brought his vocation to Rotary. With our current situation, Jerry saw an opportunity to bring forward his experience in manufacturing to manufacture masks and start the project Breathe Safely Alberta. I would like to formally introduce Jerry, who will share more about this project. Please join me in welcoming Jerry.
Hello all. Thank you very much, Drew. I don't know what you see at your end. Am I on the full screen or?
Yes, you have the full screen.
Okay. Anyway, I thank you, and I first want to congratulate all the award recipients. Well deserved. Congratulations. This session that I want to lead, we have 12 minutes, and so I'll be trying to go through as quickly as possible with the help of my two Rotarian fill-ins here, virtual Rotarians to my left. Let me introduce to you Irma and Ivan. So between Irma, Ivan, and Jerry, we'll try to get as much information to you as possible. Okay? First of all, I want to make sure that you get one takeaway from this, and that is try to get a chance to view the Breathe Safely Alberta website. Everything I will say, plus a lot more, is available on that website. Now, to pursue a little further, let's first start with, why did we do this? And this meaning the so-called mask project. We were approached by quite a few members of our community, people like the CEO of the food bank, people like ambulance drivers, some people in the medical community, and essential workers in a sense said, how can we feel more protected while we have to go out and do our tasks? And that was the driving force. What can we do to protect our essential workers? We wanted to produce something that was of high quality and cost effective. That was the beginning. Now, I only happen to be the leader of this in the sense that Breathe Safely is a nonprofit, and they needed an old guy who was pushy. I took the job. But behind that are a lot of other people, Rotarians included, and I wanted to acknowledge them so that you understand that this is a group effort. First of all, Alberta Garment Manufacturing. They are producing and cutting filters for the COVID situation and supplying the mask with filters. Alberta Injection, which is a quality injection company that produces polymer materials. Curve Distribution. You may not know that name, but you do recognize the name Dan Doherty, our past district governor. Very, very instrumental in helping us locate materials, okay? Alberta Treasury Branch. They went out and set up a GoFundMe for the capital costs of this project. Alberta Innotech, part of Alberta Innovates. To us older people, we know them as Alberta Research Council. And we had a large number of medical people, surgeons, dentists, and outside advisors as to what should we do. That was the start, and that is the group behind this. Now I'm going to turn this over to Irma. She will deal with some additional topics like just the mask. Now Irma here, being rather shy Rotarian, she wears her face with a strong smile, as you can see, and I think she'll let me speak for her. Okay? I'm holding up here the product. I'll just discuss the mask. All of the materials here are sourced in North America. In this case, almost all of it was US, and manufactured here in Calgary. Everything used here is Health Canada and FDA US medically approved materials. Nothing is industrial, okay? Just so as you know. The manufacturing of this is local. The product is made as economically as possible and is a washable, reusable unit. Again, to learn more of this, go to the website, as I will repeat this over and over. Breathe Safely Alberta will say a lot more than I can say. Now, I want to switch over to Ivan here. Now, Ivan's the kind of Rotarian that he gets very passionate and talks a lot. Like some of you people know people like that. That's a joke. So I will fill in for him as well. What I wanted to do here is talk about the term N95. We all seem to know that term, okay? With the help of Alberta Research Council, and in particular, Dr. Pistorius, he was the one that was responsible for doing our testing of materials and evaluation. I have here samples of filter material, all labeled N95. The European standard and North American standard uses a test size of 0.1 micron. Eastern part of the world uses a 0.3 micron. They're both N95s. I just wanted you to be aware, to do a comparison, as one doctor said to me, one is meant to stop a golf ball and one is meant to stop a baseball. So that will clarify you some issues on the term N95. Now, when it comes to material, we had some very critical people here. I did mention Alberta Innotech, which is Alberta Research Council, but they did all of their testing at the Nelson Lab in Salt Lake City, okay? One of the top FDA labs in the US. And they were the ones that were very instrumental in helping us come up with a good filter combination. We, Dan Doherty, again, searched the world over for high quality stuff. Very, very instrumental in getting this off the ground. But Alberta Garment, extremely important. Through Alberta Research, we sent many, many samples to Salt Lake City Nelson Labs to come up with a washable, reusable filter. And this is what it looks like, okay? Now, I don't want to talk too much about the amount of product we sent down that failed. By failing, I mean a very low N rating. This particular product, made here in Calgary, is made of 4 layers. The materials we used are on the website. Anybody can make this at home. Anybody. Easy to get product, but it's a 4-layer fine filament, and it came across on the first set of tests N94 in Nelson Lab. We redid the test, N94. High quality, homemade, and very economical. The intent was to give not only nonprofits and public organizations that didn't need a high-end N95, they could come very close with one of their own. We're finding there's quite a demand for this concept in third world areas. So that gives you a bit of an understanding of the filters portion. Now, I wanted to talk about the product overall. This was intended to go out to the marketplace and, again, offer some safety and some security to the essential workers. All don't need a high-end N95, but this product comes out into the marketplace very economically, and for Rotary, extremely economically. And each one comes with a packet of 4 European N95 filters. Again, you will find all this information on the Breathe Safely Alberta website. Now, we have sent product from BC to Ontario and also offshore. We are now packaging a pallet for a Rotary club in Southeast Asia. And so we have learned a lot. If anyone wishes to question us on that and work on a project overseas, we're willing to share. We currently have over 40,000 units produced and are producing daily. Now, I see 2 minutes, so I will try to summarize, first of all, to ask you, what can you do as a Rotarian, okay? And that is a lot, I think. Pass on the Breathe Safely website. Let your friends know. Get yourselves organized. Help your essential workers in your community. We'll work with you. This product was intended originally to be a support for the essential workers at an extremely economical standpoint. So, on behalf of myself and my 2 partners, Irma here and Ivan, we thank you for your time and stay safe.
Jerry, thank you for sharing your project. It is truly amazing what you've done and continue to do to help our front lines stay safe. And again, for all attendees, if you have questions for Jerry, please put them in the chat box. And at the conclusion of the 3 panelists, we most certainly will come back to your question and have Jerry answer them. Our next panelist, Mary Lou Harrison, is the immediate past district governor of District 7070 in Toronto. In the Rotary world, Mary Lou is an assistant Rotary public image coordinator for Zone 24 East. She is a special advisor to Rotaract Canada for Rotary family engagement. Day to day, she is the administrator of St. Anne's Anglican Church, a National Historic Site, community arts center, and vibrant parish in downtown Toronto. She's going to provide an update from the front lines in District 7070. Her philosophy in Rotary and in life is we are stronger together. With that, please join me in welcoming Mary Lou. Mary Lou, it's yours.
All right, there. I think I can both be seen and heard. So thanks so much, Drew, for that fabulous introduction. And thank you to District Governor Christine for inviting me to participate. I'm super pumped to do that. And I'd like to give a special shout out to Dr. Fazia Albi, who is a member of the Rotary Club of Airdrie, Alberta, because she and I and a new member of my club, Dr. Mosina Chaflada, are working together on a project for a COVID-19 virtual health care center, which is a project of Humanity Auxilium. So it's a nice partnership between 2 districts. All right, if we want to bring up my slides, then I will get started. Because Rotary Crushing the Curve in District 7070 has many, many components. And in order for me to share the things that I'd like to share with you and not talk too quickly, I'm going to get started. So this is Rotary Crushes the Curve, frontline responses from Rotary District 7070. And there are 8 strategies that I would like to share with you. We can have the next slide. Perfect. So some of you will have seen this hashtag Rotary Responds or might have used it in your social media. If you haven't, it is a common hashtag that we're using as Rotarians, so I would encourage you to use it. And these are some winning strategies. There are 8. So the next slide is our first winning strategy. And this is the strategy of turning to established relationships in a crisis. This is a project that you're seeing here by the Rotary Club of Etobicoke that has a very, very active hands-on committee. So this committee is already working with many, many community organizations. So when the COVID-19 crisis hit, they had the history, the trust, and the street cred, if you will, to work with their partners. So they're distributing meals, treats, and all kinds of necessary items to local shelters and community partners, some of which they would not be able to do if there wasn't the level of trust already established from previous relationships. All right, let's move on to strategy number 2. Sometimes it's an awesome strategy to use the wheel that somebody else invented. So in the first slide, we saw the work being done by the Rotary Club of Etobicoke. The Rotary Club of Toronto West, which is the same western part of Toronto, saw the good work being done and said, we can bake cookies and muffins too. So they involved their sponsored Interact clubs and their sponsored Rotaract clubs, and everybody got busy baking in a safe and socially distant kind of way. And you can see there in the pictures some of the products that were produced by the Interactors, Rotaractors, and members of the Rotary Club of Toronto West. Here I want to add a personal note that my father, who has been a Rotarian since 1961 and is still an active member of Toronto West, has been locked into his facility, not able to leave. And he has been baking cookies in a toaster oven that I then go and pick up from him so he can contribute to the project. If you're wondering what the R&D is in the little parentheses there behind the strategy, that is not research and development, that is rip off and duplicate. We have a past district governor in our club who says you should be all engaging in R&D and not reinventing the wheel. All right, let's move on to the third strategy. All right, so this idea of focusing on collaboration instead of competition and pooling resources. So the Rotarian in the pink t-shirt, you'll see there that she's got a fantastic Rotary mask. She dropped them off at my house today. It's here, which works so much better than the one I created for myself out of a bandana from the district conference when I was district governor in 2018. You'll also see that she's holding up a bottle of hand sanitizer there. So Patty tells me that the Rotary Club of Toronto West has been trying to collaborate with the local BIA or Business Improvement Area for years. But the crisis comes along and all of a sudden the BIA is willing to talk to Rotary and work together. So what they're doing is they are creating care packages for businesses with very practical things in them, including the masks and the hand sanitizers, and you can't see it terribly well in the picture, but you'll see that everything is tagged or branded with the Rotary logo. All right, moving on to strategy number 4. Sometimes in a crisis, you can reimagine your partnerships and also find new ones. And if you can hear a little bit the emotion in my voice, this is because this is a super special story. So this is a story of the Rotary Club of Markham Sunrise that was inspired by Rotary clubs in Scarborough, that I'm going to talk about in a little bit. And they thought that they would like to feed frontline workers. They worked together with 3 very active women in the community who had created a group called Canadians Care. And the Rotarians thought, let's call the local restaurants on the main street and see if we can get them to prepare meals that we could distribute to frontline workers. So when Tina, who is in the red bandana in the photo, called one of the local Main Street businesses and asked if the business would be able to, the restaurant would be able to create 600 meals, the owner said, how can we possibly do that? We can't do that. We can't donate to Rotary right now, because he was used to Rotary asking for donations. When Tina said to him, oh, sorry, no. We want to pay you $15 a meal for the 600 meals, he started to cry. He said, now our business can be open for another month. And in fact, that this project has kept at least 3 local restaurants in Markham open for the past 2.5 months. So that's pretty exciting. All right, and then we're going to move on to strategy number 5, which is personally one of my favorites, and anyone who's a member of Rotaract Canada could expect this to be the case. And that strategy is rely on Rotaractors to get the job done. So the GTA Rotaract Connect Club is an online, primarily, club in our district. And what they decided to do was to create a project called Small Acts of Rotary Kindness. And in that project, they have been doing tremendous research into various community needs in our, in sort of the downtown and broader Toronto area, and then providing small amounts of funding to those projects. So for example, they called a local food bank and said, what do you need right now today? And the food bank said, we need pasta sauce because someone just dropped off a pallet full of pasta and we need pasta sauce. So a member of the committee got organized $100 worth of pasta sauce. But it has involved so many projects. To date, the Small Acts of Rotary Kindness project has involved 25 individuals from 2 Rotaract clubs and 6 Rotary clubs, and about 400 hours has been spent so far. $4,100 has been raised, $2,000 has been spent, and 14 organizations in the Greater Toronto Area have been helped with things like PPE, games and activities for seniors, food, as well as 200 masks created by the team. And this leads into the next strategy, which is also inspired by the GTA Rotaract Connect group and the Small Acts of Rotary Kindness project, which is be kind and thank everyone you can. So the right-hand side is an image of some of the 200 masks made by members of Rotary and Rotaract involved in the project. And the other is one small example of the kind of thank you note created as a digital thank you note, but also able to be reproduced in print, that is given to an organization along with the donation. So for example, to the 519, we provided dental hygiene supplies for hygiene kits the group was putting together, and also sent them a thank you for the work that they were doing to distribute that and the other things they do in the community. This has been also part of a very large social media campaign, which, and as you can see there, is promoting both Rotary and Rotaract. All right. And this takes us to strategy number 7, create more people of action. People want to help out in a crisis, but they don't always know how to do it. And Rotarians are pretty good at figuring out who needs help, what needs to be done, and finding ways to involve other people. And at no time, I think, has this been truer than now during the COVID-19 crisis. So this was a project that came out of a smaller project pre-COVID called the House of Neighbors Project. And the young man on the right-hand side of your screen, his name is Mohammed Moyadeen, and he has been a charter president of a Rotaract club, and most recently also joined the, as a charter member, the Rotary Club of Toronto Beaches. And he grew up in the Scarborough area of Toronto, which is the eastern part of the city, in a development of fairly low-income families. And we have a very large shopping center there called the Scarborough Town Center, where he worked for Adidas. The very roots of this project were providing shoes, Adidas labeled, shoes and backpacks to kids in the community who needed them. And when COVID-19 hit, this developed into a full-scale community feeding project that involved 3 of the 5 Rotary clubs in Scarborough. And I have to say here, the other thing that makes me a little potentially teary is that this includes promotion by a past president and also current sitting president of the Rotary Club of Scarborough, Twilight Susan, who herself was at home recovering from her own COVID-19 infection. And when she saw the need that the clubs had for other partners and for money, She got herself on the phone in between taking breaths to breathe and recover, and called everyone she knows to get them on board with this project. The project itself now is using the food that was on hand at Centennial College in their culinary program and in their food services facility that was going to go bad, and now purchased and donated items through using some of Centennial College's suppliers to create food boxes. And you can see from the picture on the left that these food boxes have lots of fresh fruits and vegetables. They have meat, they have dairy, whatever a large or even very large family would need. So they've been distributing these. It's quite exciting to know that this project is already talking about how they're going to continue to work post-COVID-19 when we get to that point. All right. So, and this brings me to the very last point. And I'm sure that you all have many more winning strategies. It was hard for me to decide which ones to focus on, but this is the last one. The Rotary Foundation. Promote the Rotary Foundation. We've just created this graphic. I'd be happy to share it. So as some of you may have done, our district grant program, we now have COVID-19 grants. So we're trying to brand our grants with this thank you to the Rotary Foundation so people get to know what it is. And we'll just move to the last slide. So Rotary is certainly crushing the curve for COVID-19, but given what I have now heard from what your district is doing and just knowing what's happening in District 7070, we're also crushing food insecurity, social isolation, economic distress, unequal access to things like technology for students, and membership engagement. Any club I feel that has a COVID-19 project or projects on the go is not having an issue with member engagement right now. So does Rotary respond? It really does. Thank you to everyone who's doing such a great job, and thanks for having me.
Mary Lou, on behalf of everyone both attending this meeting and those you are helping, thank you. Very much appreciated. Okay, our last panelist, Jamie Lesueur, a hometown guy who misses hiking and camping in the Calgary Mountains. Jamie is a Canadian Emergency Operations Manager for the IFRC, currently deployed as the Head of Operations for COVID-19 for the African continent. Jamie has been with the Canadian Red Cross since 2009 and became a Rotary Peace Fellow in 2015. He is currently coming to us from Africa and will share his experience on both the Ebola outbreak a couple of years ago and the current situation of COVID-19. Please join me in welcoming Calgary's own Jamie.
Thanks so much, Drew. And first and foremost, just to thank Christine, Madeline King, Walter Halsell for the great invitation to speak. As was mentioned, Jamie Lesueur, born and raised in Calgary, sponsored by the Calgary Downtown Club for Rotary Peace Fellowship back in 2013, and glad to be back talking to Calgarians again and people from home. I'm coming to you from Nairobi, Kenya at this stage. Where, as Drew mentioned, I'm the head of operations for COVID-19 for the response across the African continent. This is for the International Federation of the Red Cross and Red Crescent Societies. It's a temporary assignment, though, as part of my regular role, which is more broadly as a head of emergency operations for Africa, where I'm often fortunate enough to be deployed to new or emerging large-scale emergency operations and disasters to set up the response and get first phase assistance out to the affected populations. So I'm going to share my screen now, and we're going to go into a bit of a presentation. Actually, would you mind giving me back the rights to share my screen, Charlene? But we'll just continue while that happens. There we are, perfect. Great. All right, so crushing the curve. What I want to do is take you through a bit of an experience that I had with Ebola. Since joining the IFRC, I've served in a few crises in Africa, but today I want to talk about one of the most complex that we, as the humanitarian community, have ever faced, and that's Ebola in a war zone. Combating this terrible virus in North Kivu of Eastern DRC, and that's the Democratic Republic of Congo. And we're going to talk about some of the lessons that we learned as, despite being a conflict in one of the nastier parts of the world, the lessons we learned from it are not as far removed as you might think. What we learned in controlling Ebola is actually, in my opinion, directly applicable to the COVID-19 response. And more importantly, each of you on this call in your action in serving above self. See, today we're going to talk about community trust and how important it is in overcoming public health emergencies. In fact, in my humble opinion, it may just be the most important element of any public health response, more so than vaccines, more so than treatment, because without the trust of the people, no one will take a vaccine. And some will actually actively try to hurt those administering clinical care. So I'm going to take you to Beni now, which, although a beautiful place, has been the epicenter of one of the world's harshest and most protracted conflicts, and one that is often punctuated by civilian atrocities. It's a place where the legacy of the Rwandan genocide is still felt, and very similar methods are employed to this day. It's also the epicenter of the second largest Ebola outbreak in recorded history that continues, unfortunately, to this day, having recorded over 3,400 cases and 2,000 deaths. The day I took over as the head of emergency operations in October of 2018 was the day the Red Cross experienced its first targeted attack. It was about 1100 in the morning when I received a frantic call from my field coordinator in our forward operating base to the south in the city of Butembo. Over a crackly phone, he said that our teams had been attacked while carrying out a safe and dignified burial, and that 2 of our volunteers were taken by an angry mob. The mob had captured them, blindfolded them, threatened to kill them. But fortunately, and through some miracle unbeknownst to many of us, our volunteers were able to escape, hiding under the bed of a local healthcare worker until the police arrived and dispersed the crowd. Our people were transported to the hospital with serious but non-life-threatening injuries. What this did was this marked the beginning of a series of attacks on healthcare workers in eastern DRC and the Ebola operation that killed at least 20 of our colleagues in 2019 alone. This attack, however, wasn't the result of the decades-long conflict in eastern Congo, and it wasn't carried out by armed groups. This violence was the result of community members who got scared and angry when they saw people dressed like spacemen entering their community and taking away their loved ones, as I think a lot of us would be. And this attack was equally then our first lesson in the importance of engaging communities properly and to build their trust before carrying out a clinical intervention, in our case, carrying out a burial. So in Congo, the Red Cross was in charge of the safe and dignified management of the dead. Ebola is most contagious after a person has passed away. So our mandate was to secure those individuals and safely inter them to avoid further infections. So why is this important? During 2013 to 2016 in the West African outbreak, 60% of all Ebola cases in Guinea were linked to unprotected community burials. And in parts of Sierra Leone, this figure climbed to 80%. So in other words, that is the majority of Ebola cases in West Africa were linked to community deaths and linked to things that were going on outside of the sphere of the urban population. So safely managing the dead is one of the key clinical interventions that's required to flatten the curve. And what we saw is that every time we didn't engage the community properly and weren't there with them throughout the process, an attack occurred. And then the caseload spiked. The direct attacks on the Ebola treatment centers in Katwa and Butembo that you might have seen on the news forced many aid agencies to scale back activities in the epicenter of the crisis. This led to the peak of the caseload in the entire operation. At the same time, in September of 2018, a massacre in Beni also led to our first major spike in the crisis. So I can preempt perhaps some of the responses. Why don't we securitize this? Why don't we go in with armed actors and police and force the population to submit? Well, West Africa showed us that this isn't the right strategy because it forces people underground. And when they're underground, they no longer alert you when someone has died of Ebola. This continues the transmission cycle where community boroughs are still given a chance to take place without protection. This is why public health responses are fought in the communities, just like Mary Lou's doing. They're fought in the communities with the people. They're not fought in Parliament. They're not fought in the Calgary Emergency Operations Center, but they're fought in the neighborhoods. And you need community investment and community ownership in prevention and mitigation measures to truly crush the curve. We found one of the most effective ways to do this as the Red Cross, but also as the humanitarian community, is to make sure the communities have the ability to engage us, and then to guarantee that we will act based on what they tell us. Too often in the rush to support as many people as we can at the beginning of an emergency, we fail to involve people in what we do, or to understand their perceptions and the complexity of their realities. In contrast, when we do listen and adapt to what people tell us, the impact on our work is significant. And I want to give you a small example of this. As you can see here, this is data from our community feedback mechanism, where we talk to people and then record it so that we know what they're saying. In October of 2018, we saw issues with safe and dignified burials, the red line there, as the second largest issue reported by communities in Potembo. That is, people were scared and did not understand why we were there and what we were doing with their loved ones. However, you can go 6 months down the road, you can see that there's no safe and dignified burials in any of our community feedback. They completely disappeared from the top feedback we were receiving. This was because we recognized it as an issue and intensified our risk communication and community engagement efforts directly to address it. Now, how does that translate into something tangible? Well, as you can see, in October of 2018, only 28% of the SDB, the Safe and Dignified Burial Alerts, were coming from the communities. However, in February or March of 2019, this rose to 81%. This tells us that the communities were more informed on the roles of our teams, but it also shows us that they were willing to call us for help, to help them look after their loved ones. Now, community alerts are essentially a proxy for community trust in our work, because you wouldn't call someone you didn't trust to take away your loved one. In October 2018, many were hiding bodies and or not reporting them. By February or March of 2019, this had changed entirely, and communities were actively calling for our help because we'd listened to them and modified our approach. This, over time, is how we got Ebola under control. And this kind of engagement and adaptation is how we maintained an over 80% success rate in SDBs over 2 years in one of the most complex humanitarian operating environments on the planet. Statistically, and to have a downward effect on an epi curve, we had to maintain over 70% overall success, and we did. So in short, risk communication and community engagement was the bolus upon which we could operate clinically. And it's because we listened, engaged, and adapted. Eventually, the communities took ownership of the response and enabled us to do our work. It's a small example of how an investment in something as intangible as talking to people can ultimately flatten the curve. It also really protected our staff because community acceptance fast became our security strategy. So how does this lesson apply to COVID? Right now, there is a tremendous uncertainty. There's a fear and anger around the origins, treatments, and prevention methods for COVID-19. Much of the evidence needed to fully inform clinical and public health responses is not yet available, making COVID uniquely vulnerable to the proliferation of conspiracy theories, misinformation, medical mistrust. And this mistrust, as it did in Ebola, deters people from seeking medical care or adopting preventative behaviors like hand washing, physical distancing, and wearing a mask. And in some cases, it results in violence, just like it did in Eastern Congo. This is a photo of protesters trying to storm the House of Representatives during the protests to reopen businesses in Michigan just a few weeks ago. Now, this is all happening in view of public information on the exponential increase in the epi curve globally, and more than 100,000 deaths in the US alone. Yet despite this knowledge, people still flout advice from medical experts, and on the weekends, they're still going to the bars. Now, there are many reasons for this type of behavior, including risk-taking behavior, economic need, general apathy, etc. But the thrust of the argument is the same as in Ebola. in that critical information that is being provided is either not being understood, it's not being trusted, or it's not being heard at all. Because in some cases, even the most senior leadership in some countries are denying the realities of the pandemic. And this has a direct correlatory effect on the epidemic curve in these places, particularly the US and Brazil at this stage. The lack of community ownership and trust in the utility of physical distancing, for instance, and other preventative measures is rendering these methods equally ineffective within the communities. Risk communication is the bolus upon which a public health intervention succeeds. And in some contexts, we have to enhance this considerably to make sure that we get ahead of the curve. Now, there's evidence that this works. Those places that have high social and political trust, that is, trust your neighbor is going to respect the same preventions you do, that's social trust, and that the political authorities are engaged in an appropriate response, that's political trust. Those are the countries that are doing the best to flatten the curve. And South Korea is a perfect example. At the beginning of the outbreak, the South Korean leadership argued that subduing the outbreak required keeping citizens fully informed and asking for their cooperation. Television broadcasts, subway station announcements, and smartphone alerts provided endless reminders to wear face masks and gave pointers on social distancing and the day's transmission data. The consistent messaging targeted at the social construct in South Korea instilled a near wartime sense of common purpose and resulted in a very high level of civic awareness and voluntary cooperation that strengthened the collective community effort. In other words, the basis of the intervention in the countries that are flattening the curve is on building trust and enhancing social cohesion. Just like we tried in Ebola, listening to people, understanding their fears, and modifying our approach to address their needs, all while seeking to increase joint ownership of the response. This is now what we're doing across Africa. 80% of our national societies are collecting community feedback on COVID-19. In the past 2 months, we've collected more than 24,000 comments from people across 39 countries. And for Canadian Rotarians who are leaders in their communities, the call to action from this presentation is for you to do the same. What you've been doing and what Mary Lou and Jerry have been doing within their local communities. That's continuing to lead by example, listening to those around you and fostering this collective accountability for the response. In your club meetings and your community actions, asking your members to voice their fears and concerns and the fears and concerns of their communities, then modifying your messaging and engagement to act as a force multiplier in the public health response. Because fundamentally, it's through organizations like Rotary and Service Above Self and the networks and meaningful engagements that you have on a daily basis that will really crush the curve. Thanks so much.
Jamie, thank you very much. That was extremely impressive. Thank you for sharing your journey with us. And for those keeping score at home, it is only 1 a.m. in the morning where Jamie is right now. So he definitely gets the award for up the latest for this conference. So I'd now like to turn to the Q&A portion of this panel. And I will begin with a couple of questions I have preset, and then we will turn to the Q&A box. And we'll start with our first question for Jerry. And I'll ask Jerry, how is the mask designed to make it more comfortable? Obviously, and I can tell you I have a COVID-19 beard, which I've been growing now for, I think, about 3 months. And wearing masks aren't the most pleasant thing right now. So what did you guys do to make sure what you have is the most comfortable?
Well, that's one area you can eliminate completely. First of all, with the beard, you got a problem there because the key issue is to create a seal, okay? And every doctor we had as an advisor, that is the very, very first thing they were evaluating. Does it create a face seal? They wanted to force all of the air through the filter, so anything entering the lungs must go through that filter. And you do suffer a little bit. Whoops. I don't know if you heard me or not.
We did. We're good.
You always suffer a little bit of comfort. I think there's 2 or 3 things that come about here. One comfort is the feeling of the enclosing of the mask. The second one was what a doctor mentioned in the earlier panel, is that you begin to have a breathing you feel that restriction. And one doctor has told me, you give that 30 to 40 minutes and your body reacts to deep breathing. So you can overcome some of the discomfort. You cannot totally eliminate it. The materials we use are very soft latex, non-allergenic, and so on. And it's the only one that's highly recommended by the Health Canada group. So there's a give and a take here. I hope I solved answered your question.
Well, you did. You're telling me, as my wife's been telling me, I got to take the beard off.
I didn't want to say it like that, but your wife is quite right. You want to create a seal.
She usually.
Remember,
she usually is.
The issue is to seal leakage air. Every other filter that you see allows it to come in from the sides and such. And when you're talking about a compromised immunity person or a person as a vulnerable sector, we have to limit the air that can get around it. So a fit is the #1 factor. And we had a nurse from the U of C hospital to instruct the people at the food bank, for example. It took her 30 minutes to talk about fit and the connectivity. And that's an important part. There's always a little discomfort.
Thank you, Jerry. So Mary Lou, you have a role in Rotary as a public image coordinator. So first, if you could just to tell this group really what that is. And second, based on your role, there's a lot of projects going on right now by Rotarians and their clubs, and obviously in your role as public image coordinator. What should we be doing? What can we be doing to kind of get that word out there that we are an organization of people of action and we're doing this great work? So I'll ask if you can respond to that.
Certainly, happy to. So the role of an assistant Rotary Public Image Coordinator or Rotary Public Image Coordinator is really to be a resource. So we're here, wherever here is, as a resource to clubs and districts who want to tell a better story. Because we have so many phenomenal Rotary stories. I touched on only a couple of them in my presentation, but we wonder, why don't people know about Rotary? It's because we don't share, and the ways in which we share are changing. So we're changing from print ad to online, but it's not just about social media. It's also about when somebody asks you, Mary Lou, I see all these posts that you make about Rotary. Do you want to tell me what that is? You better have a good answer. So the answer to part A is we're a resource, we're here to help. And so what can people do? People can understand what motivates them to be a member of Rotary. Why? Answer the why question for themselves. Why is it that you get up super early when we're able to meet and go downtown to a breakfast meeting? Or in these COVID times, why do you spend 3 hours a day in Zoom meetings trying to get stuff done for Rotary? Why is that? If you have a compelling answer to why, you're going to be able to share with somebody else for what they should do. And we should be not only sharing what we're doing with our COVID projects, but we should also be inviting other people to join us. There are virtually no barriers now other than technology for some to participating in a Zoom meeting. So we're having all kinds of guests at our club, for example. So invite someone in. It's much less intimidating to say, we're having this wonderful speaker who's going to talk about the work of Rotary in Manhattan, for example, during COVID-19. Are you interested in that? Oh, I totally want to know about that. Okay, here's the Zoom link. They don't have to listen to the national anthem or the Pledge of Allegiance, or depending on what or the Toast of the Queen. They don't have to do any of those things that people might find weird and off-putting. Valued Rotary traditions in some places. They just get to the meat of the matter. So this is the time to invite someone to join your online gathering.
Yeah, listen, there's a lot of silver linings with the current situation. I thank you for sharing that thought with us.
Not
so,
that
Jamie,
I'm minimizing the impact of COVID. I'm totally not.
No, of course. So, Jamie, how have your studies as a Peace Fellow prepared you for your current role?
A great question. And to all those Paul Harris fellows, all those young leaders, it is a very, very good experience and a very, very great stepping stone to get engaged in the Rotary Peace Fellowship. Not only what you're doing right now, but the Peace Fellowship was the stepping stone that got me to where I am today. At the end of the day, what this prepared me for was an understanding of peace and conflict from Uppsala. It gave me a first experience internationally, but fundamentally it gave me an entry point for my first job with the United Nations. I had two options. I could go to the Lebanese border and work with Syrian refugees with the UNRWA, or I could go to OCHA in Southern Africa. It was considered too dangerous by the university to go to Syria, which is fair. So I went down to South Africa, and I had a 7-month internship with OCHA, and then I did a couple months over with the UNDP on the island of Mauritius, which, again, let me tell you, was the greatest experience ever. I lived on a beach and worked for the government in the National Emergency Operations Center. But what it did was it started me more than anything, because breaking out of domestic operations is the hardest thing for anybody to do. So getting the foothold in with Rotary and getting the foothold in with Uppsala was a start. Over.
That's terrific. So Jerry, back to you. How much of the design and molding costs were covered by donations?
So far, about 5%. We just opened that up recently, and we sort of separated our costs into two categories. One, I will call startup capital costs, which is the molds and the steel work and that. And that was to be financed as much as we can through the Alberta Treasury Branch GoFundMe program. And by not putting the capital costs onto the cost of production, that allowed us to get our cost of the per unit very, very low. And we looked at the two best products in the world right now, one in Europe and one in the US. The cheapest on the market is $99 US. We wanted to get well below half of that. And so when you look at the GoFundMe, that was one of the things that helped us do that.
That's great. So on that topic, what was the critical, this comes from Franco, what was the critical success factor in the development and distribution of the mask, and what has been the impact thus far?
Well, first, the critical thing on the distribution was we have 5 distributors that have their own area of influence. And one is an international one out of Southeast Asia. And so getting awareness was the first step, and part of the program here is to do that. Second was getting an adequate supply of good quality filter. The world is full of N95. Often you see KN95, okay? But many of our people said, no, we want North American standard and European standard, which means we brought our stuff in, and that's hard to find. Our past district governor, Dan Doherty, was extremely helpful in sourcing and literally phoning every factory in the world. So that's a limiting factor, but it was overcome.
Thank you. So Mary Lou, this comes from Brian. How are the Rotary clubs in your district coping during the pandemic?
What a fantastic question. I'm so happy to answer that. So I would say that on the whole, our clubs are coping really well. We have 55 clubs. We have, I believe, 13 Rotaract clubs and even more Interact clubs. And one of the things that we're seeing is an increased level of cooperation between all members of the Rotary family. So between Interact and Rotaract and Rotaract and Rotary, and between Rotary clubs. Like anything, there were early adapters and clubs that were coping well almost immediately. There was some convincing and training and support needed for others, and there are still a few that are saying, well, eventually we'll get together again. But that number is dwindling as people realize that time is growing short. And we're able to pivot nicely on not only club events like fundraisers, we're seeing some great online fundraisers, but also community service projects now that some restrictions have eased up a little bit. But we're also seeing a pivot on some big district events like everyone here did today with this amazing district conference. So one of those is a walk that we have every year. This is year 11, and it's usually called the Rotary AIDS Polka Walk. So it's usually an actual walk along the boardwalk in Toronto in support of fantastic groups that do work with HIV and AIDS. So this year we've actually pivoted that event into being something called the Rotary AIDS and Community Health Walk, which is giving all of our clubs the opportunity to have a ready-made fundraising platform for anything that touches community health and or HIV and AIDS. So that could be food security, could be almost anything. So thank you for asking how we're doing. I think we're doing pretty well. There's always room for improvement, and there's room for inspiration. So I'm certainly going to take the inspiration from here back to everybody else here.
Thank you. We have time for a couple more questions. I will go back to Franco, who is asking Jamie, given the experience with Ebola, what can Rotary do to increase community trust to contain the virus currently?
Yeah, thanks for the question, Franco. It's a really, really good one. I think fundamentally, just like the Red Cross, Rotary has a community penetration that is unparalleled by a lot of organizations. That is, you've got people that you can go to that can give you linkages that not others can have. Now, what do I mean by this? When we were getting attacked in Benny, and we started modifying our risk communication messages, we weren't just doing it to the general public, because the general public, you can't target a message against. What we did was we found specific interest groups and interest groups that had a lot of influence. So for instance, the moto taxi unions. So the guys that literally had motorcycles and you get on the back of the motorcycle and drive around, they were the taxis. They were actually one of the larger perpetrators of violence because they were scared, because they didn't have PPE, that they were going to contract Ebola. And so they were really scared. And what we had to do was adapt our approach and adapt our messaging to them. So with the community penetration that Rotary has and with the community action you do, if you're finding in your localities those groups that are not adhering to preventive measures or not hand washing or not social distancing, that's where you target your messaging and that's where you target your community action to. And then once you get them on board, just like we did with the moto taxis, they become your ambassadors. And if they've got the influence that the moto taxis did for us, then that's how, again, you flatten the curve and you bring everyone on board and engender that community trust. So look for those that are the naysayers, target your messaging for them, engage them, and then use them as ambassadors. Over.
Got it. Thank you, Jamie. So Jerry, last question goes to you. I've been asked, how many units to date have you put out?
There's several thousand out, and there's about 30 to 40,000 ready to go. There's 2 large pending orders, and we're just trying to complete them. Now that we're fully in with having access to a larger supply of filters, we can now ship out and fill a lot of the back orders. So if any Rotary Club wants to get involved with their community, we're here. If they want to invite Emma, Irvin, and my 2 partners, we'll join their Rotary Club. We're doing that right now in Singapore and in Sri Lanka, and we have an interested group of Rotarians in Ecuador. So we have enough to supply, and we're also geared up, if we have to produce up to 10 to 15,000 per day. Currently, we're doing 5 to 10,000 per day. Okay, so we're geared up to help not just Rotary, keep that in mind. We have an awful lot of large organizations that are ordering 20,000 units at a time for their entire corporation. Okay, and that's being serviced through our 5 distributors. They deal with that issue. Myself, we predominantly deal with nonprofits.
You have a very significant operation, and again, thank you for all that you're doing and making this open to all the clubs in this district. So at this point, I'd like to thank our panelists, Jerry, Mary Lou, and Jamie. Thank you again on behalf of the attendees of this conference, as well as all those that you're coming in contact with and really helping us on the front line. So very much appreciated. I'd like to thank Christine for this opportunity and Charlene for managing the logistics. We are an organization based on fellowship and networking. And I hope that the day will come sooner rather than later that I can come out to Calgary for a future Rotary event and see you all in person. Until then, be safe, and I now turn it over to District Governor-elect Mary to promote the 2020-2021 conference. Take care.
Thank you, Drew. That was a fantastic panel. Wow, I'm blown away. I'm actually blown away by all this. We do have a video to play before Mary speaks, and we're just got our team on that right now, so just stay with us, and we'll move after that into our happy hour. Okay, so Mary, now it's time for you to speak to us about your conference.
All right, thank you so much, and thank you for showing that video for me, Christine. That's just worked out so well, just as we hoped it would. Well, hello and welcome, and my name is Mary Turner. I'm the incoming district governor for our district, and in just 25 days, our new Rotary year will begin. Today, it is my great pleasure to invite everyone to our district conference in beautiful Drumheller next May the 14th to the 16th in 2021. As the video indicated, the wait is not yet over. But on a serious note, we are not yet ready to congregate, but we will see the signs come down soon and we will be together again. There is so much more to explore in Drumheller than just dinosaurs. And I invite you and your club to come together with our very own early actors, interactors, Rotaractors, and Rotarians from across our district. Let's keep Rotary vibrant by reaching outside of our traditional ways of thinking with innovative ways to do what Rotarians do best, provide service above self. Let's take a fresh look at those winning combinations that have brought us so much success and move them forward along new pathways. It is certainly my hope and desire to have a face-to-face conference where we can look, learn, and lead together. Oh yes, and we're planning on having some fun and fellowship too, with some old-fashioned Fanny's Night with the help of our local Rotarians from Drumheller. Stay tuned. We'll have more information on that. Bev, do I wear my mask? Do I bring my feather mask? Not sure yet. We'll see. Look for registrations to be available online in September when there will be much more to share. So mark your calendars, save the date, and don't miss out on this opportunity to come together and follow the path forward to a world of Rotary opportunities. Thanks, Christine. Back over to you.
Thank you, Mary. That's our very smart and savvy incoming district governor, Mary. So thank you, Mary. Really looking forward to your year in Rotary. So this comes to the end of this conference, but please join us because, you know, you got to kiss the cod. You got to kiss the cod, and I'm probably going to make you honorary Newfoundlanders. So please, Charlene has shared the link. Please pick it up, and I'll see you in about 5 or 6 minutes. Thank you, everyone. Thank you for joining us today.